Hi, Chair.
Morning, Chief.
That's us on and fully virtual and running live on the Assembly's website and on the Assembly's Facebook page. And I think that's all our members in there as well. So you're ready to start, Chair?
Keith, just let me check again. Are you hearing me there at present?
Yes, I'm hearing you okay. You hear me?
So, Keith, I'm seeing you, but I'm not hearing you. Can you give me a thumbs up if you're hearing me? Yeah. Just let me check the audio setting here on.
Just check will other members able to hear me okay?
Yeah, I'm going to hear both.
I'm not hearing you now, Colin.
I don't have a power appeal.
Like Colin's just try to leave and come back in and see if that fixes the problem. Can you hear us now, Colin?
Yes, I'm hearing you there now. Okay, yeah.
Great.
Okay, so thank you for that. And okay, so I now declare the meeting open to the public online. And I want to welcome all of our members who are participating by video conferencing today. And can I remind members about the protocols for using electronic devices? So, members, we have one apology today from Jerry Carroll. And Jerry is on paternity leave, and both mum and baby doing well. So good wishes to Jerry on that happy news. Members, have we any other apologies, or have we a full house then apart from that, Clerk? Yeah.
For the attendance, Chair.
Okay, thank you. So members, due to time pressures this morning and the need to break at 10:50 a.m, I propose we move on straight to agenda item 5, which is the first of 3 evidence sessions on the organ and tissue donation deemed consent bill. Would members agree? Yep, thank you. And members, we have 2 sessions before 11 or before that 10:50. So it may be pressured for time, but if members have questions they don't get to, we'll accept those by email, and those can be forwarded on via the clerk, and responses forwarded back to members in that way. So just bear that in mind as we go through the session, please. Okay, members. So moving then to item 5. Organ and tissue donation deemed consent bill. We're today receiving evidence from the Belfast Trust and the Public Health Agency. This is the first evidence session on the organ and tissue deemed consent bill. I refer members there to the clerk's memo at tab 5.1 of the pack and to the other papers at tabs 5.2 to tab 5.4. And a report of the engagement event hosted by the Patient and Client Council on 15th of September. So I would now like to welcome by Starleaf, first of all, Mrs. Janet Johnston, who is Interim Director for Anaesthetics, Critical Care, Theatres and Sterile Services and Surgery. And that is quite a title. Can you hear us okay, Janet?
I can hear you. Are you able to hear me?
Yes, we're hearing you loud and clear there, Janet. Thank you and welcome this morning.
Thank you.
We are also joined... Yeah, was that you, Clerk? No, okay. Okay, so we're also joined by Dr. Dominic Traynor, and Dr. Traynor is Clinical Lead for Organ Donation. Can you hear us okay, Dr. Traynor?
Yes, I can indeed. Chair, can you hear me okay?
Yep, we're hearing you loud and clear, Dominic, thank you.
Yep.
And then from the PHA, Public Health Agency, we're joined by Mr. Stephen Wilson, who is Director of Operations. Can you hear me okay, Stephen?
I can indeed, Chair. Can you hear me?
Loud and clear, thank you. And finally, Dr. Catherine Millman. No, we have two others in this session. Dr. Catherine Millman, who is Health Intelligence Manager. Catherine, are you hearing us?
Yes, I can hear you. Thank you. Can you hear me?
Hearing you very loud and clear, Dr. Millman. Thank you.
Thank you.
And finally, this time it is finally Catherine McKeown, who is Organ Donation Promotion Manager. Can you hear us, Catherine?
I can. Thank you, Chair. Can you hear me?
Yep, hearing you all there. So listen, thank you. Obviously, that's a very experienced and knowledgeable panel. However, I would ask, maybe in the interest of time, that if one of you can lead principally on an answer when we come to questions and answers, and then only if there's something additional, so that we can sort of keep questions on members as succinct as possible, I'd appreciate that. I'll go back and check with yourself, Janet. Is it yourself that's opening up with remarks, or how do you want to deal with the presentation? And then we'll go to questions and answers.
Dr. Traynor is going to lead from a clinical perspective on behalf of Belfast Trust. Thank you.
Okay, thank you. So we'll go back to yourself then, Dominic, if you want to go ahead with your presentation. Thank you.
Good morning, everybody. My name is Dr. Dominic Traynor. I'm a consultant intensive care physician and anaesthetist in the Royal Victoria Hospital in Belfast. I'm also clinical lead for organ donation within the Belfast Trust. And since 2018, I've been the regional lead for organ donation within Northern Ireland. And back in 2008, the UK Government Task Force issued 14 key recommendations which would transform organ donation and transplantation over the last decade. And through the implementation of these recommendations throughout the NHS, we've been able to increase the number of deceased organ donors from roughly 800 in 2008 to just approximately 1,600 deceased donors per year in the year just prior to the onset of COVID. This year-on-year increase in deceased donation resulted in roughly 4,000 organ transplants per year prior to us being struck with COVID. And over the last decade, we've really witnessed a year-on-year decrease in the organ transplant waiting list. And although we're not very good at saying it, it's probably one of the biggest, most remarkable achievements of the modern day NHS when you think of the number of stakeholders involved in an organ donation and transplant. But we've really been able to bring about that change in donation and transplantation through our clinical staff on the floor having the confidence to refer potential organ donor to our specialist nurse service and also approach the family of a potential donor. What we've done over the last decade is really make organ donation a normal routine part of end-of-life care within our intensive care units. But the challenge now is really to try and make organ donation an expected part of end-of-life care. We really need to move the conversation around organ donation out of the hospitals and into the homes and into the wider society, which I think we're starting to do. To my eyes, there's never been greater support for organ donation from both the public and in the political sphere as well. And we need to embrace this opportunity. But in addition to doing this, when we're looking forward to where we want to be in the next 10 years, what we need to do is plan for a resilient, sustainable workforce, employees and healthcare staff that are highly trained and equipped with the necessary resources to allow us to do the job. And also we want to create a world-class system which the patients and the public are proud to be part of, but also have trust and confidence in. Thank you.
Thank you. Thank you. And I believe then the PHA are also doing a short presentation.
Yes, Chair, thank you. And I would echo everything that Dominic has said there. Can I just explain, firstly, that the agency as an arm's length body of the department has two main roles in relation to organ donation and transplantation. Firstly, we provide expert public health input to the commissioning of donation and transplantation services. And secondly, we're responsible for promoting knowledge and informed discussion about organ donation across all sections of the population. And that has included the agency working to develop public awareness and consultation with stakeholders over the past 10 years. Now, in relation to the first point of input and commissioning, Unfortunately, today we're not joined by our lead consultant, Dr. Catherine Coyle, as she's had a long-standing commitment, but we're very happy to take any specific questions around commissioning, etc., and public health input into that away and come back with written answers. In relation to the second role, and that's why I suppose we're really here, that of developing public awareness and engagement, obviously I'm joined by two other Catherines. Firstly, Catherine McKeown, who is the Organ Donation Promotion and Engagement Manager, and secondly, Catherine Millman, who in her role as a Health Intelligence Manager has led our research and evidence reviews relating to raising awareness and support for organ donation. I should just add, in my role as Director of Operations, I have responsibility for a range of functions, including both communications and health intelligence, and I've had primary responsibility for and oversight of the agency's public information campaign programme relating to organ donation. So, Chair, just moving swiftly on, following the Assembly's introduction of a statutory duty for the Department of Health to promote organ transplantation, the Department introduced a new policy which included for the first time a comprehensive rolling communications programme and recurrent funding. Now, it's important to emphasise that these commitments, rolling communications programme and recurrent funding, would not be impacted by the proposed move to a statutory opt-out system. The existing duty to promote would remain in place both during and after implementation of any new system. We do welcome the further statutory provisions of the Deemed Consent Bill, which would enhance this existing programme of education and communication. In relation to deemed consent, we have been working closely with colleagues in the Department and NHS Blood and Transplant throughout the public consultation, and we are now in a period of intensive planning for a comprehensive communications programme, which will roll out if the Assembly decides to pass this bill. I suppose my final point here would be that public education and communication have been and will continue to be an essential part of any change in the law. The two must go hand in hand. And I'll just pass over quickly to Catherine to say a few words about the promotion and education work.
Thanks, Stephen. So should the Assembly introduce the bill, the Department's plan would include a 12-month implementation period to enable us to roll out the programme before go live and for a further 12 months of engagement thereafter. And the programme would deliver ongoing outreach and engagement activities, which would be supported by mass awareness campaigns at key intervals. The objective is to ensure that the legislative changes are fully understood across all sections of the population and that as many people as possible are aware of the law change and how to register decisions. We have looked at how this has been achieved successfully in Wales, England and Scotland and are planning an effective communication strategy with two main phases. Firstly, the first phase would run for a period of 12 months across 2022, preparing people for the fact that the law is changing. The second phase would commence in 2023, when legislation would come into effect and would make it clear that the law has changed. It would continue to employ a collaborative approach, which is currently delivering great benefits for the promotion of organ donation. And programme development will be evidence-based using our own research, as well as research and experience from the other UK regions. And we will be tailoring our activity to specific audiences, as well as the general population, to ensure that these audiences are engaged with in the most appropriate manner for them. Engaging with children and young people is an important approach, and so the completion and launch of our skills resources will be a key vehicle. A range of other engagement work would reach out to older audiences, faith and BAME audiences, as well as working with the community and voluntary sector to reach the grassroots of society. The majority of this work would continue, as Stephen said, as part of the rolling programme for promotion of organ donation, and much of it is achieved at little or no cost due to that current coordinated and collaborative working approach. Our campaign planning will examine the use of a range of media channels to ensure maximum exposure. And most importantly, the gift of organ donation and the acknowledgement of the selfless act of donors and their families will continue to be central to all of our activity. Thank you, Chair.
Okay, thank you, Catherine. Okay, so a couple from myself then, a couple of questions, and then I'll go to members' questions, and thank you all for those presentations. This is an area I know that is there's huge interest in and huge potential in, and I do know my own colleague Pat Sheehan had proposed a similar private members bill and was pleased when he wrote to the department and they indicated that they were bringing forward this bill. So I suppose one of the things that struck me, Dominic, from your presentation was the fact that we're seeing year-on-year decreases at the present time. I think you said, now you can clarify that if I picked that up incorrectly, but could you outline what your thinking is as to why that's happening and how this bill would address that and improve the situation around organ donation?
Thank you. Yes, well, the reason that we've seen a progressive increase in deceased donation over the last decade is primarily because of the implementation of the Government Task Force's recommendations, which they issued back in 2008. The appointment of clinical leads for donation in each trust. Each trust has an organ donation committee chaired by usually a non-executive director. And other members sit on that committee, such as our specialist nurses, and they're really responsible for the governance and processes around organ donation within each trust. But really, the success of the last 10 years has come about because of clinicians working alongside our specialist nurses, referring potential organ donors and utilising what we call a collaborative approach to the family, and making organ donation a normal part of end-of-life care. We know that our specialist nurses are in these conversations now, whereas prior to 2010, very rarely they got in. And that has helped improve the numbers around deceased donation. Unfortunately, what's happened since COVID has set in is that it's set those statistics back, and we estimate that we're currently sitting in and around levels that we saw in 2014 now, which means there's probably in and around 7,000 people waiting on a transplant at the minute. Deceased donation itself also took a hit during the recent COVID pandemic, and we're starting to recover from that. What this bill would help do is place more of an expectation on the public that organ donation will be asked about in the very rare circumstances where somebody dies in the circumstances which will permit donation to potentially proceed. And that figure only stands at 1 in 100. Only 1 in 100 people that die do so in circumstances which will potentially permit donation to proceed. And so that's why it's so important for us to identify those people and refer them to our specialist nurse service. So what the law change will help do would be to create that expectation on a societal level that organ donation will be asked about and approached in those circumstances where it's clinically indicated.
Okay, thank you. And the second question for me then is around, and I'm not sure who, maybe it's Catherine or whoever thinks best to lead off on this, but how would you address concerns that people would have that they will not be fully included in the families members will not be fully included in the conversation, and that things will be done that they would not agree with or that they find difficult? So how would you address those concerns, and what would the process be in a practical sense for families if the situation arises, as you say, where it would be a potential path?
Could I answer that, Colin, if that's okay?
Yeah.
So this is a concern that has been raised by some individuals with regard to this legislative change. In these circumstances, really what we're talking about is a multidisciplinary team discussing with the family what is in the patient's best interest, a patient who's dying or dead in an intensive care unit. And as part of that conversation, we look at what the values, wishes and beliefs of that patient would be. And everything we do in those circumstances is based upon what we feel alongside with the family is in the patient's best interest. And that includes their wishes with regard to organ donation. The families are actually an intricate part of this, and they're absolutely vital within this setting, because they can tell us about what the patient's wishes would have been. They need to tell us about the medical history, and ultimately it is the families who will say yes or no to organ donation. The final decision always will rest with the family. And we've been reassured by the evidence coming from Wales. The fears that existed around the role of the family were the same whenever soft opt-out was discussed in Great Britain. And we've seen the evidence coming out from Wales that in roughly about 25% of family approaches where deemed consent comes into play, families still say no, and they can say no. At the end of the day, we're dealing with a grieving family here, and everybody involved in the process recognises and understands that. So their role won't be diminished.
Okay, thank you. I will then go to members, and I'm going first of all to our Deputy Chair, Pam Cameron. I then have Carol, Paula, Colin, Deborah and Orlia indicating at this stage. So Pam, go ahead, please.
Good morning, Chair. Thank you. And thank you to the panel for your attendance at Health Committee this morning on what's a very sensitive and a very emotive subject, but we do welcome you to committee. I have just a couple of questions in around the deemed consent and the outworking of that. And I suppose, I know many people are always very concerned that that organ donation could happen against an individual's wishes. I know that's a primary concern for many, but from my point of view, as somebody who's always carried a donor card and has always been on the register since they were an adult, my concern would be in around potential donors' wishes not being honoured. That, you know, even though an individual has made it very clear that they wish to donate, should that opportunity arise in the future, that they may have family members who would actually block that or object to that, and that then would not happen. So could you tell us what can be done to protect the wishes of somebody who's very clear about their wish to donate?
Is that question for me? I'm conscious I don't want to be hogging the whole thing. That's
for whoever would like to answer it. Thank you.
So,
well, I mean, sorry.
Go ahead. Yep.
That's a very important point that you've raised there in terms of the family's role. I mean, we know that from statistics on a UK level, since 2010, over 500 families have overruled the known wish of a patient who has, like yourself, signed up to the organ donor register. We refer to that as an organ donor register override or an ODR override. So that does happen, and in a way it comes back to my point, and in a way it helps address the fears. I mean, you could look at it in two ways. It can help address the fears surrounding the role of the family in this, because at the end of the day, we're dealing, as I said, with a grieving family, and depending on the circumstances of their loved one's death, the age of the patient, that grief can be obviously enormous. And so we do understand why in those extremely stressful circumstances, some families will not be able to cope with the questions surrounding organ donation. The best way to try and avoid that scenario is through, well, in my opinion, through public health education and campaigning around the need for people to sign up to the organ donor register and tell their loved ones their wishes and adamant, so that somebody doesn't speak for you when you're unable to at the end of life and take that decision away from you.
Thank you, Dr. Traynor. I'll ask another question then in around whether, can you provide potential numbers for organ donations within Northern Ireland? Obviously, transplantation is done on a UK-wide basis. Can you maybe just give us a very brief overview of how many transplants we do and what type within Northern Ireland and where the rest are done? And can you tell us a bit more about where access to organs comes from in general? Setting Northern Ireland's population aside on its own.
Again, if I could suggest maybe Dominic or Janet might be best to answer that one.
Well, in terms of numbers, our deceased donor pool in Northern Ireland, that is the number of patients who die in circumstances which will permit potential organ donation, is in and around 80 every year. Now, again, in and around 2008, the number of deceased donors we had was about 20. Over the last decade, we've increased that to between 40 and 50. And from the last 2 years, we've had 51 deceased donors. I think it's important here to mention the role of living donation, especially for kidney transplant, and the successes that our trust has had with regard to the living donor kidney program, which is world class. And they, over the last 5 years, they've transplanted sort of 70 to 80 living donors kidneys into recipients, which has exceeded the deceased donor program actually in Northern Ireland. If you want figures, since 2017, there's been 541 organ transplants to citizens in Northern Ireland. This gives you an idea of the number of people out there with transplants. On a UK level, there's around 56,000 people living with organ transplants today as a result of the organ donation transplant program.
That's super. Chair, if you don't mind, could I just ask one last quick question? I know we're very short in time, but I just wanted to ask in around the deemed consent and I suppose the controversy around it, and ask if you would agree with me that actually the biggest tool to increase the organ donation is almost the controversy around this type of legislation, in that forces that conversation to go from hospital to home.
Yeah, I would agree with you. The very fact that we're sitting here this morning talking about organ donation is probably something that we wouldn't have envisaged 10 years ago. So the greater the number of conversations around this issue, the greater the number of people talking about it, and even those maybe disagreeing with the proposed legislation. What'll happen if this is brought in is that we'll have basically a hybrid system where you've got the opt-in register, and we know that that's probably the greatest driver in families saying yes to organ donation if their loved one's on the register. We know consent rates are 90% in that circumstance. But in addition to opt-in, we'll have we already do have the opt-out register as well. And in those very difficult conversations, that'll bring clarity to the situation as well. In addition, people are able to nominate surrogate decision makers for them. So the choice available to citizens with regard to the decision to make around organ donation the choice has never been greater. And so the right or their will to exercise their own autonomy around this issue is also there for everybody as well.
Thank you.
Thank you, Pam. And again, bearing in mind that panel or committee members may not know who to direct their question at, if either yourself, if some of you identify who may pick up an answer, and if any of the panel want to contribute a supplementary point, if you just put your hand up physically or raise your hand on screen, I'll try and pick you up. But it is difficult to see everyone with such a large meeting, so I may miss out. So listen, I'm moving then on to Carol Nichillen. Go ahead, Carol Liddahall.
Thank you, Chair. I was just having difficulty coming off mute. Thank you, panel, for coming to the committee this morning on such an important issue. And I know Colin's already mentioned it, but our colleague Pat Sheehan was delighted when the department adopted this bill because it's so important. I don't know who's best to answer these questions, but I'll just give them to you, and then you can decide who's fit to answer. But I do think, first of all, the promotion largely has been down to the families and the organisations. They've done a marvellous job publicly to raise the awareness in conjunction with others. But I mean, mainly the families and indeed some of the lobbyists have done a fantastic job. So I want to put that in the record. So therefore, I would ask what additional, and this may be the PHA, what additional work can you do to ensure that the whole issue of organ donation receives the attention it deserves? My second question is that coming from the government, the British government's task force in 2008, the clinical leads in each trust is to be welcomed, and it in itself has made a difference, certainly in terms of communication. But the big issue in all matters of health and social care, but primarily yourselves have raised it today, is workforce planning. So in Wales, for example, there's a legislative duty on the Minister to provide resources and specialist skills. What is your feeling on that? And what are the conversations you're having regarding workforce planning to ensure that, particularly around intensivists, around specialist skills, and everything else that's needed for successful transplants, do you think we need to do? And Chair, given that we're pressed for time, I'm going to leave it there.
Thank you, Karen. Yeah, so I'll go back to the panel then. Stephen, you're on mute, or I'm not hearing you there, Stephen. I'm not sure if other members are hearing.
Yes, I was on mute. If I could suggest maybe Catherine McCune picks up the first question, and on the workforce planning issue, etc., maybe either Janet or Dominic would say a few words on that.
Thanks, Stephen. So I would very much also like to put on record the work that our partners do, particularly our charity partners in organ donation. They have been campaigning and working hard for a number of years. And since I came into post, the work and the collaborative nature of that work has been incredible, and it has made a huge difference to what we've been able to achieve in the last year. So as I mentioned, there is now a rolling communications plan for the promotion of organ donation as part of the department's duty to promote. And that is just only going to be enhanced should this legislation be passed. So as mentioned as well, it's going to consist heavily of outreach and engagement activity so that we can target as many different audiences throughout Northern Ireland as possible, and then particularly this would be happening anyway, but should the legislation be brought in, we would then also be uplifting our public awareness campaign activity at regular intervals to support that, just to make sure there is enough breakthrough and enough weight behind the messaging and the activities to reach out to as many different areas of society. So we're very much going to be hands-on, liaising very directly with networks, faith networks, NICFA and the Community Faiths Forum, the AGNI Consultative Forum, the PHA Regional Minority Ethnic Migrant Steering Group, the NICS-led Race and Ethnicity Champions. All of those networks are in place, and we're tapping into those as much as we can. We have a number of focus groups set up to engage with representatives from a range of communities to find out what do people need to know about the legislation, how do they want to be communicated with, what types of materials do they need, translations, videos, animations, to make things as accessible and easily understood for people. It can be a complex topic, talking about legislation and legislative change, so we want to make that as clear and easily accessed as possible. And then, so that's really our hands-on day-to-day engagement work, which is really facilitated and mobilised by our partners, amplifying and cascading that information. And then, as mentioned, we will be employing some public awareness campaigns for additional breakthrough and support. And we'll be planning that out very carefully as well to make sure that we're doing that in the most cost-effective way and in a range of channels that will, again, be targeting people on multiple touch points throughout their daily lives.
Thank you, Catherine. Yeah, and the second question then on workforce, please.
Janet, do you want to say anything about workforce and what we've been through over the last 18 months or so?
Happy to, Dominic, thank you. So obviously over the last 18 months in particular, Dominic's referring to the pressures that the intensive care units have understandably been in relation to COVID. And the concerns that we would have in relation to that, and obviously the need to further enhance and develop our intensive care workforce, both from a nursing perspective and from a clinician's perspective. Specifically in relation to the bill and introduction of the bill, it is important for us to have access at all times 24/7 to senior nurses for organ donation, and also then that they are fully trained and educated. And we do have senior nurses in all of the intensive care units across Northern Ireland, but equally obviously the clinical leadership that the intensivists bring to that is key. So being able at all times have access as well to a consultant intensivist 24/7 is key as part of our workforce, and key in supporting families and the nurses to assist families in making those difficult decisions. And from our perspective, there need to further build that workforce, both nursing and medical, within all of our units, to make sure that is sustainable going forwards. I'm not sure, Dominic, if there's anything further specific that you want to say around intensivists, because obviously they're the key individuals who support families alongside our nursing colleagues to make these difficult decisions at what are very difficult times for them.
Yeah, and just briefly, if you can, Dominic, and actually maybe it might be an idea if you would forward us some detail in terms of the planning that's going into workforce. Maybe we could get that via writing from you. So go ahead, Dominic.
I think in addition, just to what Janet had said, thinking of things from the transplant point of view, I mean, the document that we submitted in terms of call for evidence, we liaised with our renal transplant team about that, and they were in broad agreement with the Trust approach to this legislative proposal. But one thing they did mention, which is perhaps pertinent to mention at this point, is that, it's all very well saying we want more organ donors and organs, but part of this planning will be having the necessary resources in terms of access to theatres, staffing of theatres, so that when an organ does come up and is gifted, then obviously that we can utilise that organ. That's of utmost importance. But that's not unique to the Belfast Trust or Northern Ireland. That is the strains and pressures that we're experiencing on the system is NHS wide. So much so, I was in a meeting yesterday in the National Organ Donation Committee, and even the retrieval teams who fly over to retrieve these organs are themselves under staffing and resource pressures as well. So it's NHS wide, but it is definitely something that we need to consider in the overall context of the bill.
Okay, yeah, if you could even send us some detail on what the resource requirement would be based on improving situation. So I'm going then to Paula Bradshaw. Go ahead, Paula, please.
Thank you, Chair, and thank you, panel, for the answers so far. I've got two I don't think have been covered yet, and one of them is the issue of, I think one of the charities raised that children over 16 should be able to give deemed consent. Have you any thoughts on actually the bill lowering the age down to 16 as opposed to 18? And then the other issue for me, in particular in South Belfast, is how the communication strategy is going to address not just different cultural and ethnic sort of backgrounds of people, but also potentially language barriers in terms of getting the information across. Thank you.
Maybe the second question is again one for Catherine, if that's okay, Chair.
Yeah, certainly. Go ahead, Catherine.
Yeah, absolutely. So I outlined there the last time a number of the networks that we're currently working with, and those will be very much to the fore in terms of liaising with exactly what communities need. Obviously the PHA already do translate their public health materials into a number of languages. We use technology on our website for our publications that can automatically translate materials or read aloud for those who are hard of hearing or for visually impaired. So we will certainly be employing all of the usual accessibility criteria to our materials, but really we need to find out from the people themselves on the ground what is needed on the ground and really create those materials for people. We'll be pulling together information packs for people on the ground, and we'll be pulling together toolkits of resources for communities and community leaders and groups and organisations to push out on their channels on our behalf as well, and those will be created as needed for those people. We don't want to presume what people want, we want to find out what they need.
Sorry, just before you come on to the second question, I suppose having worked with ethnic minority community groups over the last number of years, in some ways it's not necessarily about the reading, but it's about, obviously the community leaders and educating them, making them the community educators, because I think that a lot of people have positions of trust, and they're in a really good position just to sort of talk through. So I suppose you are covering that, but I'm just making that point. Thank you.
Yeah.
Thank you. Okay, and going then to Colin Mcgrath. Colin, go ahead, please.
Thank you very much, Chair, and thank you to the panel for their presentation today. It's a very important issue and one that many people are ready and willing to support, so it's good that we're getting the opportunity for the briefing today. But I was wondering maybe if, just for one question, by way of background, could we get some update maybe on just like if roughly how many organs could be received from a donor, how many lives that would actually help if there is an average on that, just to be able to try and illustrate how many lives can really be positively impacted from somebody opting to be part of this system or being part of it, and just the impact that could have on lives. And I'm not entirely sure, does if an individual does provide those donations, are they offered on a UK and Ireland wide, or is it just within Northern Ireland that those organs are kept? What would be the rates of the use of those donations?
Chair, again, maybe this is one for Dominic if he doesn't mind picking up.
Yeah, thanks for that question. Our deceased donors and our patients who are waiting on a transplant in Northern Ireland. Currently, there's 134 patients waiting on an organ transplant in Northern Ireland. But this is an NHS-wide organ donation and transplantation programme. So organs are allocated based on clinical needs. So those for example, waiting a liver transplant at the top of the super urgent transplant list will receive a liver if it matches, as a priority. So in terms of whether the organs stay in Northern Ireland, the answer to that would be no, not necessarily. Our transplant recipients receive hearts, livers, kidneys from across the UK, and similarly when we have a deceased donor in Northern Ireland, those organs are allocated on a UK-wide basis. That's the programme that we're part of, and I suppose you could argue that given other parts of the UK have now moved to the soft opt-out legislation, it's you could argue it's time we also did that on the basis of consistency across the mechanism within which we work. Certainly in figures that we have, we can see that our transplant recipients are benefiting from the soft opt-out legislation which has come into play in the rest of the UK. So of those 541 transplant recipients in the last 5 years, 29, there's been 30 organ transplants which have come through our citizens through the deemed consent soft opt-out pathway. So patients are already potentially benefiting from this in other parts, legislation in other parts of the UK. In terms of the number of organs, the average number of organs a deceased donor can donate, has donated in Northern Ireland going back over the years is roughly 3 to 4 organs. Organs are offered out and matched, as I say, according to the condition and the clinical need on the other side. There is part of looking to the future in terms of organ donation is the concept of organ optimization, which is trying to make sure that every deceased donor is capable of donating the maximum number of organs. And that there's lots of interest in research and innovation to try and promote that within the clinical framework. And also on the transplant side of things, there's a need to increase sort of accountability and decision making around the receipt of organs. And there's a whole body of work that needs to be done on the transplantation side, just like we have done on the donation side over the last decade in terms of governance of the transplantation process, I suppose, which will help improve donation rates and ultimately transplant rates, which is the outcome measure that we're interested in.
That's great. Thank you very much, Chair. Thank you for that, Dominic. Thank you.
Okay, thank you. And I am aware there, I think Paula's question on the 16-year-old rather than 18-year-old wasn't addressed there, but maybe we could follow that up on writing if we don't get back to it before the end of the session. The clerk could follow that up in writing, Paula, if that's okay. I'll go then just for now to Deborah. Deborah Erskine, go ahead, please.
Thank you, Chair, and thank you to the panel. I suppose this is such an important issue. I personally would be strongly supportive of the principle of organ donation. The question really, I think, relates to Catherine in terms of PHA, and would it be the PHA's view that public information and awareness initiatives have effectively maxed out the rates of organ donation under the current legislative framework? And I know you talked there about the different promotional activities that they're going to be involved in should this come into legislation. And I'm just wondering how that promotional activity will differ under a deemed consent regime. Thank you.
You happy to take that, Catherine?
Yes, that's fine. Thank you. So I suppose the key thing to say here is that consistently over recent years, support for organ donation, the number of registrations of people here signing on to the organ donor register, and the number of people discussing their wishes and realising the importance of discussing their wishes has been gradually increasing over the years, but there's always more work to do. And in particular around opt-out legislation, should that be introduced. So, and we've constantly got, new people coming to Northern Ireland. We've got young people progressing through society. So we do need to be constantly informing and promoting and educating people around organ donation. And should that then also switch to a message around legislative change? So really, the key thing is organ donation saves lives. Organ donation is your decision. It always has been your decision and it will remain your decision. So really, our key message will still be to register as an organ donor, whatever that decision is, and share that decision with family and close friends. As Dominic had said earlier, it really just it reinforces your personal position around organ donation. It gives you that autonomy and that feeling of empowerment that you are making that decision for yourself. And if you want your decision to be honoured in death, then the best way to do that is to also make that very clear to those close to you, so that they will be certain of what you would have wanted should that time arise. And that's really those two key actions are still really, really relevant going forward with the legislation. The only difference will be that we need to educate people on what the legislation is, when's it coming into effect, what does it mean for them, how do they record their decisions, make it really easy for people to record a decision to opt in or opt out. But it's really about reassurance and about reaffirming, making an informed decision about organ donation, whatever that decision is.
Okay, thank you.
Okay, thank you, Deborah. I see Paula has her hand back up. I just want to check back with Paula there. It may be in relation to that additional part of our question. Paula, can I check with you? Have you your hand raised again?
It's just about the 16-year-olds, Chair.
Yeah. So, Paula, just refresh the question, please.
Well, it's just that one of the charities suggested that children over 16 should be able to give deemed consent as opposed to 18. I'm just wondering what the panel's views were in terms of lowering it. Thank you.
Thank you.
Does anyone from Public Health have an opinion on that?
No, we haven't discussed that. Dominic, I'm not sure whether you from the professional side have.
No, I know that there is a session with the charities after this. It might be worthwhile having a chat with them. I mean, I suppose from my point of view, and I mentioned about consistency across the NHS in terms of what we do, and I know in the other jurisdictions the age has been 18, and it may be prudent, at least initially, to keep with the age of 18 purely on the basis of consistency, but there may be others following us in terms of NHSBT and the charities themselves. Whenever they're here to present, they might be able to add further weight to that question. Thank you.
Okay, thank you.
Thank you. And going then to Orlia Flynn. Orlia, down the right, let it cash, let it hold.
Colin, thanks very much to the panel and for all of the feedback and the answers that you have gave so far. My first question is for Dominic. In terms of, Dominic, you raised the issue around the need for a sustainable workforce with obviously the essential resources that need to go with it. I wanted to ask what local pressures in terms of staff and resources is the service facing currently, and how quick would that system need to respond or adapt if and when this legislation is introduced?
Thank you. Well, in terms of the pressures the system is facing at the minute, they're unprecedented. I mean, in terms of the intensive care unit and units where we work, we've had to, because of the increased number of patients coming through at the minute, we've had to redeploy staff from other areas, and that's well documented. And I suppose in the context of end of life and organ donation, one of the issues with that and redeploying staff from other areas in the health service, I know that they might find that particular aspect of intensive care, the end of life scenario, particularly stressful. So we're asking people to manage a situation or be part of a situation which they may not be overly familiar with. So that places stress on staff themselves. So there's a large number of redeployed staff, and it's well documented that that's affected the theatre throughput. It's affected elective surgery. That's been well documented and discussed. In terms of resources and organ donation, the patients who die in intensive care under the circumstances where they can become a potential organ donor are already there. So these are patients with, for example, devastating brain injury, unsurvivable brain injuries, things like that. Those patients will already be in the intensive care units we're looking after them. So this legislation won't actually increase the number of the patients, if you know what I mean. But through the potential for increase in families saying yes to organ donation, it may potentially increase the number of organ retrievals that the system might need to cope with. Certainly on an NHS-wide scale, that will most likely be the case, and it's important that we try to think of ways to help deal with that. And the way to do that is to which is what we're doing at the minute, collaborate with colleagues across the NHS, find solutions and help each other's regions with regard to that, certainly in the short term. I don't know if I've answered your question there.
No, you have, Dominic. Thanks very much. And I'm conscious that, when I was asking around like the local pressures, there is no surprise there, because obviously we're in different circumstances with COVID and people have been moved around, theatre capacity has been impacted. But I suppose you answered it there. The real question was around, is our local system able to cope if we hopefully do get that increase in, organ retrieval and collection. But obviously then that's a wider conversation, that you are having, with Britain as well and with the whole system. So, no, thank you. I appreciate that answer. The second question is for Catherine in the PHA. And Catherine, it was just around the mass awareness campaigns that you are planning for. I know that there's always a big demand on a wide range of issues around public awareness campaigns and calls for the PHA to promote those as widely as possible. So I'm thinking about, like the bigger TV advertisement campaigns, the mainstream radio channels. And my question is, are you looking at those options to promote the messaging, if this legislation is passed, on those mainstream media outlets? And then just finally, is there any preparation taking place within the PHA around that training for staff within the NHS, doctors, nurses, clinicians? And also I'm thinking about, our GPs and community pharmacists. So if this legislation is brought into place, is there any programme of work to get the message out to all those outlets as well, so everyone's trained up whenever they're dealing with the public and dealing with patients?
Thank you. Yeah, so in terms of the first question, very much so, we'll be looking at a range of media above the line and below the line. So the above the line being the high profile mass media, such as TV and radio, but also looking at options such as direct mail. So we could potentially be hitting every household. And then, so through the line, sometimes described as, would be all of our digital and social channels. So that's where you get really, really targeted and really specific to audiences. We have a lot of research around, breakdown between males and females, and, how readily they talk about organ donation. So it's really tweaking individuals, say, for example, a digital ad to a male or a female audience. So we can get really, really specific, but very much so in terms of TV, etc., in terms of mass awareness. And then there's additional, the likes of Sky AdSmart, where again, you can get really, really specific to audiences. So you're only really paying for the ads that people you want to see them, if you know what I mean. So less wastage is what I'm saying. In terms of the second question, NHSBT will be, blood and transplant will be taking forward with the HSC system here, the training for the staff, but they'll be able to pick that up later on in their session to give a wee bit more detail on that.
That's great, Catherine. Thanks very much. Thank you, Chair.
Thank you, Orlia. And then finally going to Alan Chambers. Go ahead, Alan, please.
Thank you, Mr. Chairman. Maybe a question for Dr. Traynor. I suppose the bottom line is that this bill, does it have the potential to make a significant contribution to an increase in organ transplants that will therefore mean many more lives in Northern Ireland could be transformed? And does the physical transfer of donated organs between GB and Northern Ireland carry additional logistical challenges? And also, just like to finish by taking the opportunity to place on record my appreciation to a party colleague, Joanne Dobson, who first brought this issue into the political arena a number of years ago when she did try to bring a similar bill forward. Thank you, Mr. Chairman.
Thank you, Alan. Yeah, so go back to yourself first then, Dominic.
Yes, thank you. I think the first question, does the potential for this legislation, is there potential there for an increased number of transplants? I think that the answer to that is that there's the potential is there. I think that the public and political support that's evident is something that we should embrace and try to work with constructively. I think that the other regions, Scotland, Wales, England, have all moved to this, and certainly whilst the numbers in Northern Ireland for this legislative change might be relatively small, you have to think of organ donation and transplantation on a UK-wide, NHS-wide level. And certainly when you think about the data on that level, there is certainly the clear potential for this to increase the number of donations, but also ultimately increase the number of transplants, which is what we're interested in ultimately as well. It is worth saying that this is a hugely complex process, and so a legislative change in itself probably won't be enough. What we need to do is work with Catherine, Stephen, and people in the Public Health Agency to really bolster the change, and ultimately it's people, the public, that'll change the transplantation rate. It won't be the legislation, it'll be us, and we've already talked about the work going on in the community. So I hope that answers the first question. The second question was about the additional logistical challenges of transferring organs across the UK. Well, there's a number of cardiothoracic and retrieval teams on 24/7, 365 days a year, and those are the teams that would be contacted by our specialist nurses in the event that we had an organ donor consented and the process had started and someone said today. So those retrieval teams fly over to Northern Ireland and they will set up in the theatre in whichever hospital the donor's at. The retrieval operation will take place, and then any retrieved organs will then be transferred to the transplant centre, wherever that may be within the NHS jurisdiction. There are logistical challenges, and very, very rarely we have trouble with, say, inclement weather. We do sometimes get that, but very, very rarely. Usually that part of the process, the transferring of organs, in my experience, actually is quite smooth. So although it could be a potential issue, it's the pathways which exist to transfer organs to transplant centres are well established at this stage.
Thank you.
Thank you, Alan, and thank you, Dominic. And just a final one for me that occurs actually partly as a result of Alan's question there. But we have heard before that there is cooperation, I believe, across the island of Ireland and between Ireland and Britain in terms of organ donation. Is that still existing? Will it be impacted by this legislation? And is there any impact as a result of Brexit currently in terms of that type of cooperation?
Again, I think maybe Dominic, you might be best placed to answer on this one.
So I know in situations in the past, we have had a consented deceased organ donor, perhaps, whose organs haven't been suitable for whatever reason for UK recipient. And in that situation, our specialist nurses can go outside of the NHS and offer that organ to potentially some of the Republic of Ireland or into Europe. And we've certainly in Belfast Trust had a team fly from Germany to retrieve an organ that wasn't suitable for any UK recipient. So there is cooperation within and between countries on this issue when the need arises. There have been potential implications from Brexit, but I think that you have a session with NHSBT after us, and there'll be people on that who would be better placed to answer that question than me, actually.
Okay, thank you. Listen, I really appreciate your attendance this morning. It has been rather rather shorter than would have liked, but we've got through a lot of key business there. And if members have any other questions that they didn't get a chance to ask, please forward those to the clerk, and he will process those for response. But for now and for this morning, Janet, Dominic, Stephen, Catherine and Catherine, can I thank you all for attending, for your presentations and your answering of members' questions, and wish you all the best for the future. Thank you.
Thank you, Chair.
Thank you.
Thank you.
Okay, members, I'm going to go directly to the second session then, and we can pick up on any matters arising after we do our third session that's just been referenced there after the break. So I'm going to go directly. I'm going to just check with the clerk that we have everyone online that we need for our next session, item 6.
We do indeed, Chair.
Okay, so members and panel, item 6 then is the Organ and Tissue Donation Deemed Consent Bill, and today we're receiving evidence from the Donate for Dahi campaign, British Heart Foundation and Kidney Care UK. This is the second of our evidence sessions on the bill, and I refer members to the written submissions at tab 6.1 to tab 6.3. So I would now like to welcome, and just check sound, first of all by Starleaf, Mr. Martin McGowan from the Donate for Dahi campaign. Martin, can you hear us there okay?
Yes, I can indeed, Chair. Thank you.
Okay, to Falcher Road, Martin. We're joined by Fiona Loud, Policy Director of Kidney Care. Fiona, can you hear me okay?
I can hear you. Can you hear me?
Yes, we're hearing you.
Fantastic.
Actually and metaphorically loud and clearly. Thank you. And we're joined this morning then by Fergal McKinney from Policy and Public Affairs Manager with the BHF. Philip or Fergal, can you hear us okay?
Good morning, Chair. I can hear you okay, and I hope you can hear me.
Yes. So we're hearing all of our panel there fine. I want to welcome you all to this morning's meeting. I will just say again that it is, I think, hugely significant and hugely a great development that the second actual meeting that myself and Pam Cameron as Chair and Deputy Chair did was with the Donate for Dahi campaign. We had the privilege and the honour of meeting with Marcin, Seth and indeed Dahi, the main man himself. I just want to acknowledge the amount of work that you have put into this campaign and bringing, as some of our members said in the earlier session, bringing this conversation out of hospitals and into homes. And I think all of you have done that. Many others have done that as well. And I do acknowledge Alan's point around Joanne Dobson having brought forward a bill. My own colleague Pat Sheehan had sought to bring forward a bill and was delighted when the department indicated that they were going to do so. I think it's a very important issue and I want to acknowledge and credit you all. And I think in particular, Marcin, the way that yourselves have engaged right across society in a very positive, a very vibrant, at times a very joyful campaign, highlighting the fact that Dahi is just a wee man that needs a heart, he needs it sorted. There's lots of people out there in the same situation, and he has brought a tremendous spotlight onto the issue. So in that spirit, I will go ahead and ask you to maybe go to give us any presentation or opening remarks, and then we'll go to members' questions. So in that sense, I'll go back to Fiona first of all, then I'll come to Fergal and then Marcin. So Fiona, or do you wish to make some opening? And if we could, the other thing I'll say is, if we could keep it very brief, we are under pressure for time this morning. The session will have to be brought to a conclusion at 10:50. If there are outstanding questions from members or answers that you haven't had a chance to fully reflect, if you could do that by writing via the clerk following the meeting, it'll take some of the pressure off the time. So I'll just check with yourself, Fiona, and then I'll go to Fergal and then Marcin.
Thank you, Chair, and thank you very much to the committee for the opportunity to speak this morning. I'm Policy Director for the UK Kidney Patient Support Charity, Kidney Care UK, and I'm only here today because of an organ donation. I spent 5 years on dialysis, and 15 years ago I was fortunate enough to receive a kidney from my husband, Keith. However, there are so many other people who are not fortunate enough to receive a living donation. It is for them that we absolutely applaud and support the move here towards the change in law to give more people the opportunity to receive that life-transforming transplant. Here in Northern Ireland, we are proud as Kidney Care UK to have our, you've already referred to her, our Northern Ireland ambassador, Joanne Dobson, herself a living kidney donor to her son Mark, and former Assembly member and committee member as well, of course. And our kidney recipient, William Johnston, our advocacy officer in Northern Ireland as well, himself another kidney recipient. We're proud to be able to support the population of Northern Ireland who have kidney disease with our grants, with our advocacy, and that's grants to patients, that's grants to hospitals, and of course all the information we're able to produce and much more. And we commit fully to supporting the public campaign as this goes on. 7 out of every 10 people waiting for a transplant are waiting for a kidney. Kidneys are the only transplants which are actually taking place in Northern Ireland, and our living kidney donor programme is the jewel in the crown, both nationally and internationally. But as I've already said, for the deceased donations, that is where we're at today. There are 80 people currently waiting on a kidney transplant in Northern Ireland. There are probably more than that. You heard Dr. Traynor previously talking about how some people are not necessarily active on the waiting list because of COVID-related issues. Some of those people will die over the next few years as they wait for a transplant, and we need that to change. Some kidney patients will need more than one transplant in their life, and a transplant is a gold star treatment, but it's not a cure. And we must never forget the generosity of organ donors, of course, as we go through all of this. So we believe that changing the law is the right thing to do, but it's not the only thing to do. As others have said, learning lessons from colleagues who started to tread some of these paths before in the rest of the United Kingdom. Rigorous and sustainable funding for the first year is that before the law comes into place, once the law comes into place, and then onwards to keep reminding families and members of the public what the situation is with the law. In that way, we will be able to consolidate these changes. We'd like to see infrastructural funding in place for the capacity you heard Dr. Traynor talk about before, training for intensive care staff, and the ability to make use of fantastic new technology to preserve organs. We talked about children and young people already. Catherine McEwen talked about that work. They are the change makers, and we'd like to see that continue, very much targeted at people in Northern Ireland, because they will be the people who'll be influencing the families. You've heard already about Dati. There are other young people and children who are currently waiting for transplants in Northern Ireland, including David McKenna, who some of you will know, whose mum just let us know yesterday that 5 years after his transplant, he's now on the way, unfortunately, to needing another transplant. So in conclusion, I'd like to say that passing this bill would be the best Christmas present that this committee and this assembly can give to the entire transplant community in Northern Ireland, many of whom I'm sure are watching this today. That's the gift of hope. And we urge swift passage. We know you're on a tight timescale, and we offer our continued support in the weeks, months and years ahead to make a success of this, to strengthen the success of the bill and improve outcomes for people whose lives now and in the future stand to be changed by the opportunity of that life-transforming transplant. Thank you, Chair.
Thank you, Fiona. And Fergal?
Thank you, Chair and committee members.
Your sound, Fergal, let me just, your sound is quite poor. I'm not sure if you can turn it up a little, but certainly be aware of that. Your sound is a bit poor.
Okay, I'll try and speak up as much as possible if that's helpful.
That's better.
I'll just read a short statement if that's okay. I'd like to thank you, Chair and committee members, for giving us the opportunity today to appear in front of you to discuss this important piece of legislation. We've previously engaged with many of you, and we thank you for that. And much has happened since all of these discussions began. This time in November 2020, we were awaiting the launch of the consultation from the Department of Health on a move to soft opt-out. We recognise the depth and breadth of that consultation, and that it has proved beyond doubt that there is support here for a new soft opt-out system. We're now at the committee stage. It's been a long road to get here, with many people campaigning on this issue. If there was one message, Chair, from British Heart Foundation today, it is that we urge you, the Health Committee and all Assembly members, to continue that progress on this legislation so that we can see this legislation passed before the current mandate ends. The prize is a great one, a real opportunity to change the lives of those who are on the transplant waiting list. The most up-to-date figures show there are 134 people waiting for an organ transplant in Northern Ireland, 15 of them waiting on a new heart. Legislation here will complete a UK-wide picture. Since 2015, we've seen the difference the change to a soft opt-out system has made in Wales. There's been an increase in both consent rate and donation rate, as well as support from health service staff for the change in organ donation system. England and Scotland have recently started their journey with a soft opt-out organ donation system. This is gift of life legislation, and we respectively urge that swift progress. With your permission, Chair, can I just read? I got an email this morning from a family in Guildford. Donna McGoldrick, her son Josh, received a heart transplant in July 2018. And she says, and I think it's important to bring it back to this, organ donation is immensely important to our family. When Josh was critically unwell and we were told on several occasions treatment would be withdrawn, we were broken. No parent ever imagines their child could lose their life before them. It's unimaginable. When a miracle happened and Josh was strong enough to be put on the organ donor list, we were given back hope. When our prayers were answered and Josh received an offer of a heart, we were given the most precious gift for Josh and our family. Thanks to organ donation, we have our son and brother with us every precious day. We never forget how special that gift is every day, and we never will. Our family has stayed complete thanks to organ donation, and we are forever extremely grateful to Josh's organ donor and their family. Thank you, Chair.
Thank you, Fergal. Martin, Leanna Ray, Lida Hull.
Guramaga, Chair, and thank you to the rest of the committee as well for giving us this opportunity to be part of the session. I'm absolutely delighted to be speaking to you all this morning on behalf of my family and the Donate for Dahi campaign. We would also just like to acknowledge, Chair, just the role that the committee has played and getting to this stage. You know, back in that cold January morning, when we met yourself and Pam, you know, for it to be at this stage I believe it's remarkable, and I just want to put on record my thanks to the committee and playing that role. And just as Fergal was saying, we would just really urge the committee to continue with that, that level of dedication to this, because we really do need to get it through in this mandate. Excuse me. Just one of the aims of our Donate for Dahi campaign, or the overall aim really, and it would be the same as a lot of other campaigns like ours. It's to normalise the talk around organ donation in society, and we truly believe that this law changing here, it would be a massive step in that direction. I've said before that it's not the wave of a magic wand and, all our problems will be fixed, but it's certainly a massive step in a societal change, in our opinion. Now, I'm not a politician, nor is Seth, nor is Dahi. However, as politicians, you're all sons, you're all daughters, mothers, fathers, and even brothers and sisters. There's no right or wrong way of finding out that your child's or your loved one's only and last chance is to receive a donated organ. Every single case is different, and people they handle the news differently. And I've had people ask me many times why we put so much energy into this campaign, and the answer, it's very simple for me, and it all starts back in October 2016 when Dahi was born. And when Dahi was born, I personally, I felt this love that I've never felt before. I can't put into words or describe that love, but it's there. And, the best way to describe that is I cannot directly protect my son. I do not know for sure what lies ahead in his life, and I can't give Dahi exactly what he needs. And for any parent, that's heartbreaking, and I know there's many others in my position and Seth's position as well. But what I can do is I can spend every day, every week, every minute of my life to try and normalise organ donation in the hope that people do say, yes, I donate. And we do believe that this, as I said before, is a step in that direction. Let me just take you back to what organ donation is, and I know you've heard it already this morning, but it's a organ donation. It's a last hope for people like Dahi. And what we are trying to say is, imagine that there's something that can be done by our political representatives to increase the chances of our loved ones. And, this is something that the vast majority of our politicians support. it's the vast majority of our clinicians support, and more importantly, it's very clear that the public supports this as well. So I think it's safe to say that it means absolutely everything to us for this to go through and this mandate and be made into law. And, we welcome any questions that the panel might have. And Garamagov, thank you for the opportunity again.
Okay, thank you, Marcin, and thank you all. And I think that really does bring it right down to what you described there, that feeling. Marcin and I have had the honour of having that feeling with my own children, and I can understand how not being able to provide that very important life-saving treatment, the impact that could have. I also want to recognise the hope that's out there that you've all talked about and our role in that. And I think Pam and I in that first meeting did say that we would do everything we could. You certainly have played your role in terms of keeping it on the agenda, and I think the committee have delivered in a sense of keeping that. And we are also conscious that, and we continue to commit, and we do commit today, that we will do everything in our power to make sure this does get over the line in terms of the scrutiny role of committee and the rigour and all of that needs applied, but also to keep it moving forward. So I'm going to go first of all to Pam Cameron. I'll pick up on anything at the end of the session if I think there's anything overlooked. As I said, we are tight for time. If one member of the panel can give a substantive answer, and then only if there's additional important information that someone wants to contribute, we'll try to move. We'll try to move across. So I'm going to go to our deputy chair then, Pam Cameron. Go ahead, Pam, please.
Thank you, Chair, and thank you to Marcin, to Fiona, and to Fergal for your attendance at committee this morning. And as I said in the previous session, this is a very sensitive and a very emotive subject for many people, but no more so than people like Fiona and Marcin here today. So thank you for telling your stories. I think that is important, that everybody has an opportunity to hear what organ donation means on a very personal level if they haven't experienced it within their family. Congratulations to Dahi for getting another birthday by him. Marcin, that's wonderful news, and I think we were all celebrating with him and for you all when he hit 5. So that's wonderful, and I hope he has many more, and I hope he gets that heart that he needs and deserves. I suppose just one generic question, really, maybe aimed more at Marcin, and that's around, obviously, children are not covered under this legislation. So could you just explain from your part how you believe this legislation on deemed consent, if passed, will help the likes of Dahi and children?
Thank you for your question, and thanks for the well wishes. He had a brilliant birthday, by the way. So I totally understand the question, and to be honest, we do believe that we do agree with the current situation that it should be adults that should be considered in this law. 47% of the consultation. 47% of the consultation came back and said that children should be excluded from this. But I want to maybe bring a bit of attention on to 37% of the people that come back to the population or to the consultation. They said the children should be included. Now, I do believe, as I said, that it should be adults only. However, I do believe with the 37% coming back, I think this opens a door for us, and maybe it's a different question for pediatrics and organ donation. Now, how I think this will help Dahi is that I think that this, and I've said in the opening statement, that this change of law, it's a massive step in the right direction of normalising organ donation in society. Now, public awareness campaigns, education, etc., have to go hand in hand with this, and all of this, in my opinion, with society changing to organ donation being the norm, can only benefit children or children like Dahi directly. Also, with the public awareness campaign that will take place, the amount of conversations that will take place about organ donation in general because of this can only benefit us, because we know what the benefits of organ donation and transplantation are. And we are very confident when people hear those statistics and figures that they, or the vast majority of people, will continue to support organ donation. So I hope I've answered that in the, if I haven't answered clearly, or if you want me to clear anything up, just ask.
Thank you, Martin. And also just to reiterate the point that if there are any further clarifications or whatever, we can send those through and they can be dealt with in writing. Or if there's detail that you think is not going to get fair play today in terms of timing, then we indicate that and you can send that on. Fiona's indicating there. Go ahead, Fiona, please.
Just really quickly, just to say I've just been in conversation with David McKenna's mum, who I mentioned earlier, who's about to, unfortunately, his first transplant. He will need another transplant in a year's time. She fully believes that actually, as Martina's just said, by raising the debate, the discussion we have here, for people to understand what this means to children, they'll understand more about what it means to adults as well, and that will increase the opportunity for organ donation all over for children as well as for adults. So this is a knock-on benefit to from the changing of the bill and from the public debate. I hope that helps.
Thank you, Fiona.
Thank you, Fiona. And we do send our best wishes as a committee out to each and every person out there who is watching this, who is waiting or hoping or needing a transplant, and indeed every one of those people who has considered going into the opt-in system and is watching this and will be prompted to do so today. Please do that. You don't need to wait for this legislation to sign up, but it will improve. So, okay, listen, Pam, are you okay for me to move on then, or? Have you had your, yeah, thank you. Okay, so going to Orlia Flynn. Go ahead, Orlia, please.
Thank you, Colin. And I also just want to commend all of the panel here today, Fiona, Fergal and Marching, for all of the work that your respective groups and charities have done in getting us to the point where we are today. And as Colin says, of course, we are thinking about every single family that's been impacted or are being impacted by this issue. But I do want to give a special congratulations to Marching, to Dahi's daddy. I just think that you have done an absolutely wonderful job campaign. You should be so proud of yourself for what you have done. You have really raised the bar on this issue. And that's bringing me round to my question, Marching, I suppose, because in my opinion, you have done a lot of the heavy lifting in terms of awareness on this campaign for a very long time. Obviously on behalf of your son, but you're doing it on behalf of everyone that's gone through this issue. So I wanted to ask Marching, and if any of the other panel want to contribute as well. In the previous session, I don't know if you got to listen in, but we're hearing from the PHA on how they intend to roll out a mass awareness campaign once hopefully this legislation is brought over the line. And have you had any engagement with the PHA on practical ways that they can do that? Because you had said earlier, Marching, that all this is around normalising the conversation within families and households. So I think that your input would be greatly valued, and that's my question, if you have had any conversations or engagement at this stage with the PHA. Thank you.
Well, thanks for your question. And, I would say not a day passes where we don't speak with Catherine from the PHA. And, Catherine has included us and used us so we have a great working relationship with the PHA, and we have complete faith in Catherine and the team that they will be able to, have a massive public awareness campaign. And we do believe that one of the biggest benefits of this whole thing, is the massive public awareness campaign that will come along with soft opt-out organ donation becoming law. We have seen, more recently in England and Scotland, before this law came into place or came into effect, there was massive public awareness campaigns, and that's to make people aware of what exactly is happening. And it's very important that during this time of the public awareness campaign that the public know exactly what's happening, and as I've said, I'm very confident in what the benefits of organ donation is, to people like Dahi, that people will continue to support organ donation and actually choose to join the NHS organ donor register. We just believe that, especially with I just want to add as well that, this won't be the end for our campaign. The way I look at it, it'll just be the start. We'll have to just raise more awareness and just make people aware, because it's as Catherine was saying earlier, just with the radio and the TV and the newspapers and the conversations that will be happening around breakfast tables, dinner tables, and just in general in workplaces. It's something that we're really looking forward to, and it's an opportunity that we can't miss.
Thanks a lot, Marching. Garmy Agat Colin.
So going then, I have it now, at this stage now, I have Colin, Paula and Carol who have indicated. So I'm going to Colin Mcgrath firstly. Go ahead, Colin.
Thank you very much, Sharon. Thank you to the panel, to Fiona, Fergal and Martin. And yeah, I mean, just the campaigns that everybody has been doing has been so inspirational in trying to push forward this issue. But I just really love how we can derive so much inspiration from at the time, a 1-year-old, a 2-year-old, a 3-year-old, and now that he's 5 from Dahi. That just speaks volumes how humanity can reach to us from children, and we should listen and learn from the experiences that they're going through. And I suppose with so many issues in Stormont, so controversial and divisive, it is really great to see that we have got the backing here behind this bill, that its pathway should be fairly simple and swift. And that it's good that whenever it comes to such issues that we really can rally together and work well together on it. And I know that there are still, I would hear of people out there that are still unhappy with the concept of donations. And I was wondering if, from the panel, if they have had any experience of talking to people that maybe have had an epiphany and have changed their perspective from maybe being against donations to now being pro and supportive of it, and maybe just to explain what their understanding of that was, because I think that could be a powerful message to the people out there that we still need to bring along with this. Has the panel had any experience of that?
Maybe I could make a comment there, if that's okay, Chair.
Yep, certainly.
So one of the reasons that we were keen to speak today was also to bring in some of the experience from the whole of the UK on this as well. So some of the points that have been made already, and I must commend the work of Catherine in the promotions agency, is about the transparency on this. So actually, no question is stupid. So when people ask questions, it's about answering those questions clearly, directly, and being able to engage. So any of the engagement that we've been part of previously, in other parts of the country, has been about talking to donor families, letting their voices shine across this as well, because what and I can't possibly speak for them, but for the families I've spoken to, what they say is that their wishes, their thoughts were respected by encouraging the conversations with people. We heard I think it was Dr. Traynor say earlier, and Chair said here today, there's no reason to wait for the law to change if you think that organ donation is the right thing. There are nearly 1 million people in Northern Ireland who've already put their name on the organ donor register to say that actually they do support it. That's a really, really powerful message. So we're coming from a position there of strength, but by engaging with the faith communities, the different communities, sometimes putting funding in, as Catherine has mentioned, to specific awareness events, targeting work. That's the way in which it works. It builds trust. It reinforces the messages that we're saying today. So I would absolutely encourage, learning from what we've seen before in other parts of the country, that engagement and the continued work with families to explain that, their views, their thoughts, while the law is changing, they are as important as ever to this. It's just that the default has changed in a way that some families have already told us has made it easier for them not to wonder and not to do the kind of story that I've heard where, people have had to, have the difficult conversations. This makes it easier for them, and it still retains that respect there. I hope that helps.
Could I add, Chair?
Yes, go ahead, Fergal.
Just not dealing with in the singular, Colin, but the Welsh experience has been that since 2015, consent rates have gone from something like 50% to well over 70%. So that tells you, our research tells you that 90% of people here support, but only 50% actually sign on to the opt-in system. And experience on a global scale tells us that countries that have employed the soft opt-out system have seen hugely increased donor rates. So the evidence is out there. On the issue of engagement, if I could just add, and reflecting back to the previous question as well, just think what has been achieved through a number of small organisations in Northern Ireland and the Donate for Dahi campaign and others joining in terms of raising the profile for this. So just think what a sustained and coordinated campaign of engagement with the wider public going forward could achieve for the soft opt-out system, not for itself, of course, but for those people. And there are 134 people waiting on the organ donation register here, 15 of them waiting for a heart. And the imperative is, and there's a tragedy behind this, is that 14 people died on that organ donation register last year.
Yeah. Okay. Thank you, and that's very sobering, Fergal. Yeah, and that is kind of the real story out there. Okay, I'm going to go ahead then to Paula Bradshaw. Paula, please.
Thank you, Chair. And it's really just to pick up on the question they asked the last panel, and it's around whether they feel that the age should be lowered to 16 at the time at which people give deemed consent. Thank you.
Yes, Martin. Go ahead, Martin, and then Fiona.
Thanks for your question, Paula. Just to bring it back to the public consultation, where 47% had said about that children should be excluded, and that would be anyone over the age of under the age of 18. Sorry, now me personally, I'm a teacher, and I my personal opinion would be that I would have no problem with it being for the age of 16. But as well, that what I'm also thinking is that to join the organ donor register, children can still join the organ donor register. Parents can still sign their children up to the organ donor register, and just being in schools and visiting schools with Dahi, the amount of parents that have contacted us, and the amount of people at 14, 15, right up until 18 have reached out to us to say, I've spoken with my parents, I want to join the organ donor register, and I have joined that. It's been incredible. And just to bring it back with the Public Health Agency and with Catherine, I'm on one of the groups with other teachers, and we're working at raising. We're working on education and stuff like that. So to answer the question bluntly, me personally, I wouldn't have a problem with it being 16, but I also was listening to Dominic earlier saying for it to be in line with the rest of the UK. So it's something that that I wouldn't see a problem with, but I'm also okay with it being adults only over the age of 18 because of the reasons why I mentioned with the NHS organ donor register as well.
Thanks, Martin. Gormayagat. Fiona?
Yeah, just to say that we would say that keeping it consistent with the rest of the UK would be a thing that we'd recommend at the moment. Things can change as we go forward, and as Martina just said, all of that engagement, that education is incredibly important. When my son, he's not little anymore, but he was 13, he put his name on the organ donor register because what he saw happening to his mum. So we knew what his wishes would have been had he ever had that terrible thing ever happen to him. But actually, the education, the empowerment we've discussed already, but keeping it consistent in order to keep this as successful as possible and as easy as possible for our agencies would be what we'd recommend at the moment, I feel.
Okay. I should have said at the start, thank you all for your campaigning around this, and I think it's a really exciting time, and I look forward to working with you going forward. Thank you.
Thank you, Paula. And the final indication I have on screen at the present time is from Carol. So, Carol Nicolin, Lanaray, Lesh Carol.
Okay, Gormagat, Carol. Thank you, Dahi, Fergal, Martin, Fergal, and Fiona. I'm sure you've heard the previous submissions, and one of the points that I raised was I do think the level of awareness now is probably where it's never been, so that's to be welcomed, and I do appreciate and acknowledge all the work that you are doing, and I do think our public health family possibly could do a bit more, but sure, that's like everything in life. The question that I had probably isn't relevant to yourselves, but given the fact that there has been ongoing difficulties around workforce planning, particularly around intensivists, and I did mention, and I think Fergal, you raised it as well, around Wales, where there is a statutory duty for the department to ensure that the proper resources in terms of staff are there. What discussions, if any, have you had and with the department or even the PHA? And my last, I suppose, point is that, I mean, a lot of people would not have thought about registering to be a donor. I mean, I didn't think, to be frank, about it. I thought about it, but didn't do anything about it until a woman, Nuala Valady, died. She was a casement stalwart, and she was on the organ donation register. And then we had Joanne, and we had Joe Brawley and Shane Finnegan, and then, of course, came Martine and Seth and Dahi and many others. But it all does come down to awareness, and then the ugly but practical stuff around resources. So it's just to try and get your own views on what else do you think that we as a committee could do, and what else would you like to see the departments doing? So, Gormelgov, thank you.
Thank you. Fergal, are you looking to come in on that one?
Yeah, I think it's important that Carl has hit on what is, you know, if you like, the legislation is the framework within which this can happen. Here is
Fergal, just pause a second there. I think we're losing your sound badly. I'm going to check with the clerk if that's the same for him.
Yeah, we're losing it a wee bit there.
So Fergal, if you just start again, please.
I'm just going to shout this time in terms of hopefully that you can hear me, but I'm shouting solely for the microphone and not emotively just. But Carl's absolutely right. The legislation on its own will not work. It needs to have sitting beside it resources for a proper information campaign so that people are fully aware of it. It also needs resourcing and training for all staff involved in transplantation. But reflective of Martine's comments earlier on, the bar for this will be around how organ donation will become, if you like, the norm in our conversations. And that in itself will put added pressure on the system to be able to deal with the demand in that system.
Okay. Thank you, Fiona.
Yeah, just to endorse exactly as Fergal has said and as Carol said earlier, this committee can help by continuing to engage with and support PHA, and as I said earlier, to make sure that we are evaluating the resources that are needed to make this a success, and continue to, as we monitor it as we go along, that will be really important, as well as putting in all that support to start with. And if I can just make a separate comment, I'm actually chair of a local organ donation committee, so with a different hat on. So I round up with a hospital that is a donor hospital. So you can see from first hand that training that was just talked about for intensive care staff and the constant support for those hospitals from which the donations come is very, very important, as well as supporting the transplantation side of things as well. And that's something that this committee can do by looking into that, by giving that support and helping with the infrastructure to support all of this.
Okay.
Thanks.
Thank you. Okay, and listen, I think that's been really useful. I have to say I do welcome the fact that there appears to be a good level of coordination and cooperation with the PHA in terms of communication, and I think that's welcome, and it's probably an indication as to why it has been so successful at this point in time in raising awareness. However, is there anything that you think at present that could or should be getting looked at in terms of further highlighting the awareness, and indeed the critical point of moving from people supporting it, genuinely supporting it, but taking that step to put themselves onto, and I know that's partly what we're trying to address, but in the interim, do you think anything more could be done to move people from the thought to the action and to click and to sign on for organ donation to try to improve the levels? So who wants to come in on that?
So I'll kick off if I may, Chair. just telling those stories, you've heard Marcin tell Dati's story. The more we tell the stories of people who are facing organ failure, the more that people will feel, the compulsion, not the compulsion, but the motivation to put their names down, to share their decisions about organ donation with their families. Because that's one of the things that we've seen from Wales and we've seen from England as well, is that actually, it's not just about changing the law. It's not the magic wand. That's a really, really important message. But to encourage people to continue to have those vital conversations, what makes it easier in the unthinkable situation in which you might become a donor. It's far more likely you might actually need a transplant than you would ever become a donor. But that level of appreciation, working with the donor families as well. We've talked about those before as well. So bringing their stories forward as well. That's some of the ways in which we can engage, and we look forward to working, and we certainly can commit Kidney Care UK and our kidney family in Northern Ireland to do everything they can to work with that. And I know that Joanne, who'll be watching this, will absolutely be a part of that. Thank you, Chair.
Okay, thank you, Fergal.
Yes, Chair, thank you for the opportunity. I think a lot of the conversation here this morning has been about support for organ donation. And I think it's important to reflect and underscore again that this is a soft opt-out system. There will be people out there who do not support, and emphasis should be put on that they have the absolute right to be able to underscore that for themselves, and the system should be in place so that they can easily do so. Now, we've reflected on the fact that 90% of people in Northern Ireland support organ donation. Similarly, that is in Wales, and a big percentage, of course, supporting soft opt-out system. In Wales, only 6% of people actually decided to sign on to the soft opt-out system. But it should be articulated again that that's available to them. And I think harmonising those two views, allowing people to fully opt out, but still allowing for the system to be maintained and efficient for the vast majority of people, then that should be underscored.
Okay, thank you, Fergal. And Marcin, I think it's appropriate maybe that and Fetal Impairment, the last word would go to yourself. And if there's anything you want to say in terms of any closing remarks or whatever, please go ahead.
Yeah, no, well, unfortunately, Dahi's at school, so he can't close the session today. But what I would say is that we do have a massive opportunity here, and I'm talking about the law change. And I would just, I agree with everything that Fiona and Fergal has said about the personal stories and all that. But just on the potential law change, that it's a massive opportunity that, I've said before on many interviews that this may take a few years to come into effect. So we need to do it now. It needs to happen now so that we can see the effects in the next maybe 5 years instead of the next 10 to 20 or whatever years. So I would just appeal to our elected representatives to do the right thing. And, I also love to have I know there will be people on the public watching today, and I also love to have a wee opportunity just to say, please consider in the meantime joining the organ donor register and have that conversation with your loved ones, because there are too many loved ones' wishes being overruled because people are unaware of your decision. So the conversation is just as important as joining the NHS organ donor register. So please do it.
Okay, thank you, Marcin Goramila Mayagat Marcin, and thank you to each and every one of you and everyone who has campaigned so far to bring this to the stage it's at now. And just to reiterate that commitment from us as a committee that we will certainly play our part to try to get this legislation on the books as soon as possible, to try to get those figures up. And please send our well wishes all to David, to Dahi, and to everyone out there who is watching today with hope, and we certainly will try to play our part in delivering on that hope. Okay, thank you all. Thank you, panel. Okay, members, I'm going to now take a break in the meeting to allow members to attend the remembrance session that's taking place in the Senate chamber today, and we will resume our meeting at 11:25. So that's 11:25 to resume our meeting in live session. Thank you, members. Okay, so I'm just checking then with Clerk that we are ready to go, Clerk.
Yes, ready to go, Chair.
Okay, thank you. So our meeting is now resumed in public session, members and panel, and we are moving then to item 7, which is the organ and tissue donation deemed consent bill evidence receiving today from NHS Blood and Transplant. This is the third evidence session on the bill, and I refer members to the written submissions at tabs 7.1 to 6.3. 7.1 to 7.3, I think that should read. I would then like to welcome by Starleaf from NHS Blood and Transplant, Mr. Anthony Clarkson, who is Director for Organ and Tissue Donation and Transplantation. Can you hear me okay, Anthony?
I can hear you loud and clear. Can you hear me?
Yeah, we're hearing you perfectly, Anthony. Thank you. We're also joined by Dr. Dale Gardner, who is Associate Medical Director for Deceased Organ Donation. Can you hear us okay, Dr. Gardner?
I can hear you fine. Hope you can hear me as well.
Yep, we're hearing you there fine. Dale, thank you. And finally, in terms of this panel today, Mr. Phil Walton, who is Legislation Lead. Phil, can you hear us okay?
I can hear you very well. Hopefully you can hear me.
Yep. So we're hearing you fine there. If I can just remind members to remain on mute when you're not speaking, and if I can ask the panel to identify who might lead on a particular question when we come to members' questions, and then if there's supplementary information, if anyone wants to add, that's fine. But if we could have a principal kind of a response, just for in the interest of time. So I will go back to yourselves, gentlemen, and see is it who is going to lead off in terms of any presentation.
It's me, Chair. So
okay, well listen, you're all welcome to our meeting this morning. We appreciate your attendance here, and please go ahead then, Anthony, and give us your opening remarks.
Great. Thank you, Chair, and thank you for the opportunity today. I'm Anthony Clarkson, the Director of Organ and Tissue Donation and Transplantation at NHS Blood and Transplant, which is the organ donation organisation for the UK. As you've heard, I'm joined by Dr. Dale Gardner, who's our Associate Medical Director for Deceased Donation, and Phil Walton, who leads the operational implementation of the change in legislation. Between us, we have been involved in the planning and successful delivery of deemed consent legislation in Wales, Jersey, England, and now Scotland. I'll start by saying how pleased I was to see how aligned the bill is to the Acts in Wales and England. This approach reduces the complexity and risk and allows us to draw on a wealth of experience we've gained in working with the other countries. The alignment means that our work will ensure the development of clear, practical, and above all, safe guidance for specialist nurses and clinicians to work to. It will also reduce the time and funding required to implement the change in legislation. You will have had concerns raised about whether organ donation is no longer a choice under an opt-out system. Our experience across the other countries demonstrates that trust is not eroded as donation remains a choice. Also, the families have always been and will continue to be central to organ donation conversations. Without them, we cannot determine the last known decision of their loved one. Furthermore, without the family, important medical history would not be possible to collate. And without this, it is unlikely that transplant surgeons would be willing to accept and transplant any donated organs. Integrity of the medical practice in end-of-life care has improved trust in organ donation systems over the last decade. Sometimes we hear concerns that doctors won't try to save my life because they want their organs. But this is not the case. Those caring for patients are solely concerned with providing treatment to save the life of the individual. Organ donation is only considered when all options for life-saving treatment are exhausted. I would also like to touch on another concern we've heard being raised. That is the notion that donation as a freely given gift is affected by this proposed legislation. Organ donation is and will always be a precious gift, as each person still has the ability to choose to opt in or out under an opt-out system, and families will still be asked to support their decision. Furthermore, the Order of St. John Organ Donation Award is the public recognition of the gift given by that donor and awarded posthumously to their family. I would like to say that if the legislation is passed, we hope that it will have the desired effect and increase organ donation, because, after all, that is what we all want. However, furthermore, transplantation is cost-effective. I mention cost-effectiveness because there is a focus on measures to increase consent and donation rates. However, if those organs are not utilised, we will not get the transplants that we need. It is therefore important to ensure that transplant services keep pace with the anticipated increase in donors. One of the key factors for success in donation systems is new technology that turns previously unusable organs into usable ones, so we can fully honour the gift of donation and the decision of the donors to save lives. Finally, I want to offer my thanks to the Department of Health for working in collaboration with us and others such as Kidney Care UK and local trusts, giving us the opportunity to provide advice on implementation options as the bill has progressed. It does mean that we're in a strong place to implement should the final legislation be passed. I'll finish there, Chair, and thank you, and any questions for us now.
Okay, thank you. I suppose the first question from me is in relation to something that you referenced there, Anthony, in terms of that trust has not been eroded as a result of the implementation of this legislation in other places. Can you outline for us how that was achieved, or what you put down to that trust being maintained in the system?
I can. I'll go to my colleague Phil, who led the implementation and did a lot of work on this. Phil.
Yeah, we might have a bit of a joint answer here, Chair. So from a nursing perspective, I think transparency around the implementation. So working closely with medical colleagues in how you're going to deliver the legislation at the bedside and the conversations that you have with families, but specifically going out to key demographic areas and giving an overview of how the organ donation process works, because I think there is a lack of information in the public domain about what happens when you're admitted to hospital and the process that you go through before organ donation is even considered. And I think specifically a focus on the fact that organ donation is completely independent of end-of-life care or even treatment. So somebody arrives in hospital with a medical emergency, those clinicians and nurses looking after that patient have no interest in organ donation at that point. Their sole point is to save the life of that individual. And that sometimes is conflated. The message around organ donation is conflated with what people think are going to happen, like pick people up off the side of the road after they've been hit by a bus. That sort of thing just does not happen. So we spent a lot of time on messaging and then making sure that our clinicians in the intensive care units are very clear about their role in the delivery of organ donation, particularly under a new legislation. So that was primarily my focus, but I think Dale may have some additional comments that would be helpful here.
Yeah, thank you, Chair. As an intensive care doctor, much like Dr. Traynor was earlier, we've seen these fears of lack of trust or undermining the gift we had when Wales was the first to bring their legislation in 2015. We have not seen it. The intensive care community, who I represent and work with and still have an active job on intensive care, families still see this as a gift. Our doctors and nurses on intensive care, they know that actually we will respect the families and care for them. And our job is to find out what is right for that person. And this just helps it easier. We hear over and over again how the legislation helps. It's quite scary as an intensive care doctor to walk into a family and give them terrible news and then to also talk to them about organ donation. But the legislation has made us feel confident that actually we have the societal backing to go and have those difficult conversations with families. And that's helpful for us. I would say on a public societal view, tonight I'm speaking at the British Islamic Medical Association and one of their meetings. That opportunity has really come because of the legislation change, that they actually want to engage and we want to engage with them and we want to talk and have proper dialogue between different groups. And that trust has been built and they can see that we still respect families and we can make that point very clearly. So I think it helps us in intensive care and is good for helping that dialogue in society.
Okay, thank you. The second question then that I have is around resources, and we have had some discussion with our earlier panel. So I'm just wondering what advice you can give us from the experience, and you've referenced that you are some way ahead legislatively on this process. So what advice could you give us in terms of what level of planning is needed in terms of workforce and resources, particularly given the fact that we have a very, very stressed workforce situation already, and going forward we need to have not only the consent but also the capacity to improve the situation. So who may take on that answer, please?
Yeah, Phil's probably best placed again, and I'm happy to come in, Phil, if you need me. Yeah.
Yeah, of course. So I think let's look at the context of what this proposed legislation might do to the increase in donation rates, because I think it's important to put it in that context. So if we work off the baseline consent rate that we've had in Northern Ireland over the last 3-4 years, we're looking at about a 64-65% consent rate. If this legislation goes some way to support an 80% consent rate, which is what we consider to be world class, we're looking to increase donation rates by about 10 to 15 donors per year. And that's spread across, of course, about 10 intensive care units in Northern Ireland. So from the first point to make really is that from an organ donation capacity point of view, we don't see this increase as being something that is unmanageable. In addition to that, those patients are already on the intensive care units. As I said before, patients are admitted to intensive care units for treatment, prognostication and time to have their life saved. And only when life-saving measures are exhausted will organ donation be considered. So we're not admitting more patients onto intensive care units solely for the purpose of organ donation. They are already there. So from that perspective, again, we don't see it as an unmanageable capacity issue. I think finally, from a Northern Ireland organ donation services team point of view, like you've identified and others have also, they are stretched. And I think there will be some investment required in just making sure that we can maintain a robust service. But again, not unmanageable. And I think we've been working closely with our colleagues in the Department of Health to identify what a budget might look like to support that robust running of the organ donation services. Anthony, I don't know if you've got anything else to add.
I don't think so. I think, as you say, we've been working closely with the Department of Health on this. It's not we wouldn't need a huge increase in workforce, but we would need to ensure that we are available and able to respond to any increase in donation. So we've done some figures around that, and we've shared those with our sponsors, so they have that information. On the transplant side, though, I think we need to, there's work to be done to consider transplantation too. So that would be working with the commissioners and the transplant units to ensure that they're able to respond to any increase in transplant numbers that may come as a result of the change in legislation. Again, because the numbers are relatively small compared to the other countries, the impact wouldn't be unmanageable, I suspect. So.
Okay, thank you. And the final one from me then is, in an earlier session we had heard that there has been some impact in terms of, and I know that there are linkages across Europe, and that is particular resonance here where we share a small island with another jurisdiction, and the potential, but also potentially the problems that can create. So in terms of to date, what has your experience been in terms of any impact in terms of Brexit, and what work is ongoing to address that, or what consideration needs to be given to improve rates right across for all of our people?
Yeah, I'm happy to have a go at that. So in relation to Brexit planning, we did extensive Brexit planning, which actually which worked well. We've seen very little impact on organ donation and transplantation as a result of Brexit. We continue to share organs where an organ can't be placed in the UK. We continue to share those across Europe, including Ireland. So there is that will continue. So far it has been a smooth transition, I'm pleased to say, for organ donation and transplantation. And we hope that will continue. Now, of course, the rest of the world are also pushing hard. So all countries in Europe are also pushing hard to increase the number of organ donors. Every country is aiming to try and get to self-sufficiency as much as possible. So hopefully we'll all be moving in tandem to increase donation. And of course, many countries in the world are looking to the countries of the UK to see how they progress with the change in legislation, to see if that's something they would want to consider implementing too.
Okay, thank you. Okay, I'm going to go to committee members then. So at this point in time, I have Carol, Pam and Paula indicating. So I'll go to Carol there. Carol Lanerai, Carol at the Hull.
Thank you, Chair, and thank you, panel. I mean, I don't know if you were listening to the previous presentations, and you are all fairly in concert with each other, which is to be expected. But I do think the 80% world-class standards is something that everybody's trying to achieve, and certainly with the implementation of this bill, it would definitely go a long way to reaching that target. But the question they asked others is something that's just a persistent issue with us, and it's in relation to workforce planning. And certainly the example that I used in Wales, that there is a duty on the minister to provide specific or bespoke resources. So what are your concerns, given obviously we're still coming out of a pandemic, but certainly for us here, health budgets have been increasingly challenged despite the fact that there has been an agreement from other executive colleagues to prioritise health. What are your concerns around the workforce issues in relation to the successful implementation of this bill?
I'm happy to have a go, and then I'll bring Phil or Dale, happy for you to come in. So in relation to workforce, I think we are all acutely aware that there is huge pressure across the whole of the UK. And in fact, I speak to colleagues around the world and they're having similar issues post-pandemic around the world with workforce in healthcare, as there seems to be what they're calling the Great Resignation. But in organ donation, we've been quite fortunate, and particularly in Northern Ireland, actually, that we've got a very experienced and stable specialist nursing team. And we're very proud of that team. They are generally, as I say, very experienced and mature team, which pays us dividends in the fact that they create some stability, which is useful because we're not able to draw on the other countries because of the geography in the same way. So the team has to be quite robust, and that comes to our comments earlier. My concerns are that we work very closely with the team to provide them with support, particularly because, of course, dealing with death, all the time is not easy. And actually, post-pandemic, we have seen elements of burnout. A lot of the team went back to support intensive care in the wider NHS during the height of the pandemic. So we've worked very closely with the teams to ensure that they have the support. And so far, we've been pleased to say that we've been able to maintain our levels of specialist nurses. Having said that, we do recognise that in the wider NHS, the pressures are there on organ retrieval and in transplantation. And I'm sure Dale will perhaps want to comment on the wider pressures in intensive care that might impact. Dale?
Yeah, no, thank you. I think it has been a terrible sort of burden that all of society, but the front line of the hospital has very much witnessed and experienced, and a lot of intensive care is now short of nursing staff around the UK. With regard to organ donation and transplantation, I think we would hope that the commitment by members of the MLA here and the whole Northern Ireland Assembly, that they would, at least commit to ensuring that the resource is there, whether that's as part of legislation or whether that's actually as part of the fact of your own commitment here today and elsewhere. That can be achieved. We've been very fortunate in organ donation and transplantation with government support over many years, and we count ourselves grateful for that compared to other areas of the NHS. And with that support, we've actually been able to build that success story you heard earlier from Dominic Traynor about how we have increased donation. We just need to take your support to take that next step now.
And I think it's also worth just noting, I know you'll know this anyway, but I think it's worth noting that transplantation is a cost-effective form of treatment compared to dialysis, and therefore it does free up funds back into the wider NHS. In a stretched economy as we are at the moment.
Okay, Carol. Yep, thank you.
Thank you, Chair.
Yep, going then to Committee Deputy Chair Pam Cameron. Go ahead, Pam, please.
Thank you, Chair, and thank you, panel, for your presentation to committee today on what's a really, really important subject. And Phil, you touched upon the circumstances in which organ donation may come about, and I think that is really important. I just wondered if you wanted to take the opportunity just to maybe walk us through, a particular example of how organ donation and the subject would come about, the circumstance, and because obviously there are perceptions out there that actually there are more availability of organs than there actually is, and we understand as a health committee that those opportunities are actually very limited and very restricted. So if you could even just walk us through a particular example, I think that might be useful for anybody listening in. And then if you could tell us what you believe that the impact of this legislation, if passed, would have on those particular circumstances. And I'm thinking about in terms of the interactions with the specialist nurses, for example.
Yeah, absolutely. Thank you for the question. So if we use an example that has been kind of used in some clinical engagement events that we've been undertaking more recently, the very first point is the rarity of organ donation as an opportunity. So in the UK and in general, there are around 600,000 deaths that happen every year, and less than 1% of those die in circumstances, so on an intensive care unit attached to a ventilator or a life support machine, as more commonly referred to. So it is so rare for organ donation as an opportunity to come up. I think once you then start applying medical contraindications and those sorts of things, that 1% diminishes further and further and further. So that's the context that we're talking about. If we put this into a practical example of a patient who has had an out-of-hospital medical emergency, they've been admitted to the emergency department and then transferred to the intensive care unit, they'll meet a doctor like Dr. Dale Gardner or Dr. Trainer that you met earlier on. And they will be assessed through a series of tests. So it might be a CT scan, a load of blood tests, all of those sorts of things to see what it is that they can diagnose as the issue and then instigate treatments that will save that individual's life. And that is the sole purpose of their admission, is to save their life. Now, this period of time may be anything from 12 hours to 3 weeks. It could be anything in between there. And at that time, you remember that the family are at the bedside, the family are going through this as well as the individual and those caring for that patient. But there will come a time in that process where an organ donation is possible, where doctors will understand that every instigated treatment so far has failed and that there are no further options. And therefore, we're going to have a conversation with the family about their loved one not surviving this admission and they're going to die. Only at that point, so as I've said, it could be 12 hours, it could be 3 weeks, but only at that point where a decision has been made that this patient is not going to survive is organ donation considered. So we'll get a phone call in the organ donation team, somebody like me or from the organ donation service will arrive, have a conversation with the consultant and discuss the possibility. So we'll have to have a look around any medical contraindications or anything like that. And then we'll plan to go and speak to the family. So we need to know who the family is or who the people that are close to that individual are, discuss how we're going to break the bad news, how we're going to talk about organ donation, who's going to lead on what section. And it goes into real minute detail just to make sure, because this is, you get one chance to do this type of conversation well, and the family will remember if it's awful. So we plan this conversation as well as it can be, and then we'll go and deliver that. And someone like Dale will lead the conversation around ending life-saving treatments, and I would lead a conversation that brings in organ donation. And at that point, the family will either say yes to donation or no to donation. If it's no, then we would move down a route of kind of ending those life-supporting treatments sooner. And if not, we would talk about how organ donation will progress and the opportunities it will present to that family. This legislation only has an impact, and I've talked for a few minutes now, I do appreciate that, but it only has an impact during that organ donation conversation. And it presents itself in a way that where a family have no idea of their loved one's position on organ donation, so whether there's a registration on the ODR or whether they've had a verbal conversation about it, deemed consent legislation only has an effect where there is no indication at all. So again, vanishingly small occasions where this will have an impact. But what we do hear from families, and particularly from Wales, because they've got a greater experience of it, is it gives them that confidence to say, well, they've not objected. They wouldn't have been unwilling. They're the type of person that would have told me that they didn't want to be a donor, given all the publicity and all those sorts of things. So it gives them the confidence that by supporting donation, they're doing something that is in keeping with their loved one's values, characteristics, and wishes. I hope that answers your question.
It does. Thank you very much. Thank you, Chair.
Okay, thank you, Bob. And Paula Bradshaw then. Go ahead, Paula, please.
And thank you, Chair, and thank you, panel, for coming to the committee today. The question I wanted to ask is in relation to whether or not you feel that we should be listing those organs and tissues that can be transplanted or those that cannot, and whether that should sit on the face of the bill or sit within secondary legislation then that could be amended going forward. So it's really just about what model you think would work best here in Northern Ireland. Thank you.
Okay, thank you. Dale, I know you've got experience of dealing with this in Scotland. I don't know if you want to share that.
Yeah, I think when we've seen actually the bills in Wales, England and Scotland as they've gone through, secondary legislation does make it easier. As medicine evolves, it can be quite difficult, as you know better than me, to change primary legislation. And as certain organs may be easier to transplant in the future, which we don't know yet, it makes that a lot more simpler. And the same way as you can actually modify any sort of restrictions you may need as well. So we would favour and support a belief, like the other three nations have done, of using secondary legislation to allow that. But we do need clear guidance, and it's difficult to operate outside without that. And so we definitely need something that tells us and then tells all the society which organs are acceptable and which are not. And we would recommend, much as what the other three nations are, of this legislation initially only being relevant for the heart, lung, liver, kidneys, pancreas, the typical organs that we do, intestine and corneas and other tissues, other typical ones, and not anything else that people might think of or maybe possible in the future or more common, not yet, as we cement this legislation.
Okay, thank you. I suppose that just as a follow-on then, in terms of the other nations of the UK, do any of them go further in terms of donation for clinical trials? Obviously, we're a health committee here. We're as much about prevention and development of new technologies and treatments and stuff. So, are any of the other nations actually doing some sort of partnering legislation to look at donation for clinical trials? Sorry, thanks.
Dale, do you know the answer to that?
The answer is not at the moment, but we have just embarked on a major clinical trial in donation called the Signet trial, where we hope to recruit 80% of our, technically the donation after brainstem dead donors over the next 4 years. And that's possible through grants from NIHR. We're waiting for hopefully Belfast to come online within the next few weeks for that trial. So big supported research can happen with or without this legislation. But what it can do is families that generally say yes to donation, say yes to research. It's in the order of 85 to 90% of families that support donation. It will then go and when research is offered, they get a lot of comfort from knowing, and in some ways research may save even more lives than actually what they may save from the initial transplant itself.
I think that's the important point here, is that families are very supportive of research. Interestingly, once they're supportive of donation for clinical use, they then, as Dale said, very supportive of donation for research. And we do facilitate that directly into research or to the possibility of a research tissue bank where tissue can be used then for further research.
Thank you very much. Thank you.
Okay, thank you, Paula. Okay, and I'll just I have one other question myself, and I'll just give members the last opportunity to indicate there should they wish to. But in terms of the duty that's in the Welsh legislation, panel, to provide resource, is that something that you think has worked within the Welsh context and would be useful within the legislation that we're considering?
Phil, do you want to comment on that?
Yeah, absolutely. So the answer to that question is I don't see that it's been utilised as part of the Welsh legislation, in that from an organ donation perspective, I think that there is certainly a duty for intensive care units to be better staffed and the transplant units. So from that side, it may well have had an impact, but we don't get to see that. From an organ donation point of view, we've not had to kind of pull that lever, so to speak, from the Welsh government to increase our resources. Would I recommend it? I think this is obviously a question that we can perhaps bounce to the Department of Health themselves, but I think there would be, I guess, a note of caution about putting financial kind of imperatives on future ministers for health, I guess. But that's a consideration for yourselves as politicians about whether that's the way to go forwards with that.
Okay, well, listen, I want to thank you, gentlemen, for your presentations and your dealing with members' questions. And that has been a very useful addition to the committee. So I want to thank you and wish you all the very best in the time ahead in the very important field of work you're doing. And we share your hope that this legislation can see improvement in the figures and that we can increase the provision and the benefit of organ donation as a result. So thank you for that.
Thank you.
Thank you. Thank you. And thank you for your great work. Thank you.
Okay. Thank you, gentlemen. Okay, members, I'll just check then. I think there is a number of things have been indicated for further information, but is there any other comment that members want to make before we resume back to the start of our meeting, if you like? We've dealt with 3 sessions there. So is there anything across the 3 sessions that members want to flag or raise or suggest? No. Members content enough. And Clerk, you will have a note of any of the issues that need picked up on. Okay, members, so then I'm going to return to item 2. So we are going there to Chairperson's business. In relation to some of the concerns that are arising over the past number of days around healthcare staff and the mandatory vaccination, would members agree that we write to the Minister and ask what consideration he's given to that issue at the present time? We're aware there's been a consultation announced, but I think it would be useful to get a broader view from the Minister as to what considerations he's given to that issue. Are members content with that? Yeah, thank you. I also think I do want to note the worrying increase that we're seeing in case numbers and the pressures that is potentially putting on people initially from developing COVID-19 and also on the healthcare system. So I think that's something that we will be very keen to raise with the Minister and Chief Medical Officer when they're with us in a couple of weeks' time. I also want to note the fact that the Period Products Bill has passed second stage and we will be engaging with the Education Committee on that bill. So thank you for that. Okay, members, I am going to move on to draft minutes. I refer you to the draft minutes of the meeting of the 4th of November at tab 3.1. Are members content with those minutes? Yeah. I also refer members to the meeting of the 9th of November. That's Tuesday's meeting there, which are tab 3.2 of the table papers. Are members content with those minutes? Yeah. Okay, and I see where Alan is looking to raise an issue then in matters arising. So, Alan, do you have a matter arising from the minutes? We're not hearing you there at the minute, Alan.
It's just three issues in relation to the presentation that we received from the General Medical Council. I've had an opportunity to reflect on some of the things that they said to us and also to read the correspondence that they sent to us. The first issue was they told us that the legislation that they operate under is the Medical Act of 1983, and they did say that this situation around Dr. Watt was rare. They didn't say it was unique, it was rare. So it has obviously happened before that someone has used this particular loophole in the Act to avoid an investigation. So they in their written submission to us, they say that they have been, for many years, they have been calling for changes to aspects of the Medical Act. So I would like to maybe, if we are writing to them, to maybe ask them the direct question: have they been calling for changes in the Medical Act that would close this particular loophole? And as I say, from their words, it's obvious that they have had previous experience of this loophole being used. The other thing that they
Alan, just let me pause there, Alan. I'll pick up. I'll just check committee agreement on that, and then we'll move on to the other issue just for clarity. So our members agreed with that approach? Yeah. Okay. Great. Thank you, Alan. Alan. Go ahead.
The other thing, Chairman, that I picked up in their written submission is that, and there was no mention made of it in the, I don't think in the oral presentation, that clinicians are subject to 5-year formal confirmation, reconfirmation of their standards of being able to practice medicine. And I'm just wondering if, in fact, if there is a report every 5 years on a doctor, they must be holding those reconfirmation reports on Dr. Watt. And in fact, I understand that perhaps Dr. Watt was receiving more intense observation because of adverse reports that had been coming in around him. So I think it would be useful for the committee to have sight of at least the most recent, or maybe even the two most recent confirmation reports that were carried out on Dr. Watt, because they would have to be signed off by supervisors. And I think it would be interesting and useful for the committee to know, who signed it off, and were they satisfied? It's like a school report. Was it satisfactory? And if not, what action was taken? So if we could ask if it would be possible, it may not be under data protection, Chairman, it may not be possible, but if we could ask if it would be possible to have sight of those reaffirmation reports, I think they maybe call them, and it might give us a steer as to just what did they know about them.
Yeah. Members content that we seek that information? Yeah.
Sorry,
yeah. And the third.
Yes,
go ahead.
Just
who's looking in there?
Yeah, just for clarification, they did advise us that Dr. Watt undertook a revalidation in 2013, and that was the only revalidation that was undertaken. So he would have been due another one in 2018, which never happened. So I think we can certainly agree to the right to request a copy, but the information they provided last week was that there was one revalidation done in 2013.
Yeah. Well, yeah, go ahead, Alan.
I think it would be useful for us to have sight of that, just to see, because I mean this predates 2013, the concerns around Dr. Watt. So I think it would be useful to see that. Just was there any? Did the supervisors flag up anything, or was it an absolutely clean report, nothing to see here? So I think it would be useful for the committee to have knowledge of that.
Yeah, and just linked to that, I had raised that issue as well around the revalidation, and there's also a linked issue around annual appraisal within the Belfast Trust. It has never been really clear who was responsible for doing the annual appraisal. I think maybe it would be useful to ask for clarity around that issue as well, if members are content.
Yeah, absolutely. Yeah. The third thing, Chairman, then just was, I think it might be useful from a lobbying perspective if the General Medical Council have been trying to make changes to the Medical Act. We certainly have identified a major loophole here that has let down a multitude of patients in Northern Ireland. And I think that loophole of this voluntary erasure has to be closed. I think it would be worthwhile to write to the Department of Health in Westminster and the responsible minister and highlight our concerns that loophole exists, and that the government should maybe going forward give consideration to adjusting and amending the legislation to close that particular loophole.
I think actually that might have been addressed by Pam last week. I think we might have written. I'll just check with the clerk. I think we may have asked for that letter. Clerk, can you advise?
Maybe Jubilee.
Last week we agreed to write to the Westminster Committee on Health to ask them to liaise with the Department of Health there on this particular issue.
Yeah, I'm happy enough for that, Chairman. Yeah, thank you.
Yeah, and separately, but again linked to that, Alan. Would it be? It may be useful for us as a committee to even seek legal advice through the clerk as to whether or not we could look at taking forward. A health committee could take forward legislation to close this voluntary erasure loophole, because it does appear to be quite an open door for a way for people to escape or avoid scrutiny. So maybe, clerk, could we look at taking some legal advice of our own in relation to that issue?
Mr. Chairman, yeah. I've just questioned. I'm not sure that, given that it's Westminster legislation, this Medical Act of 1983, it may not be within our remit But I mean, I'm happy enough to do anything that closes this loophole, but I'm just, it may not be worth, spending money on legal advice and stuff if in fact it's ultra vires as regards the even stormont. But it might be worth establishing that before we get in too deep in seeking legal advice.
Yeah, so Clerk, can you do that kind of screen it and see if it's appropriate? And
certainly, I'll speak to the Assembly's legal team in relation to this just to see where the responsibility lies for this legislation, to see whether it is Westminster or there's something we can do in the Assembly on it. So I can certainly follow that up.
Okay. And Carol, I think you were looking in on an issue on this item as well. Yeah.
I was. So, Chair, just following on from the points that Alan has raised, I know that even just from publicity, I'd look back on some of the publicity in this over the weekend, that either the Belfast Trust and or the Department of Health at the time conducted an independent review of neurology services. I think it was called the Veritas Report, or an organisation of completely independent clinicians to look at the services provided under neurology. So I'm assuming the committee has already got this, but it would be helpful as a committee if we could get this. And again, not unredacted, but with data protection redactions in that. None of us are asking for people to be exposed. And then just following on from last week, could we get an agreement, Chair, at the committee to write to the Professional Standards Authority regarding the MPTS decision? Because it was quite clear the GMC were completely frustrated, despite the fact that the MPTS is a subcommittee of theirs, just to get an opinion from the Professional Standards Authority, because this just keeps going round and round in circles, and we need to actually pin this down on what can be done to make sure this doesn't happen again. Thank you.
Yeah. Okay, thank you, Carol. Members agreed that we seek that information that Carol referred to there, and also that we seek the view of the Professional Standards Authority in relation to the process that was undertaken here. Members content with that? Yeah. Okay, members, thank you. That's helpful. Thank you. So there's no further matters arising then from the minutes, and the clerk will reflect those issues back to us again in his report. So moving on then, members, to organ and tissue donation that's item 5, which we have covered. Clerk, I just want to check with you, are you okay technically in terms of the minutes dealt with? Will you be bringing back those addendums to next week's meeting?
No, we'll get them agreed in this week's minutes. We'll put a note of what was agreed by the committee, so the minutes from last week and from Tuesday are all signed off, but what the committee agreed today will be in this week's minutes. Okay,
perfect. Thank you. Yeah, that's perfect. Thank you, members. Okay, then, so we're moving on then to item 8, which is the Health and Care Bill, the consideration of the report on the LCMs. So I refer members to the draft report on the 3 LCMs that have been laid in respect of the Health and Care Bill at tab 8.1 of the pack. Do members have any comments they wish to make in relation to that report? No. Are members therefore content with the report as drafted? Yep, members content, thank you. Moving on, members, to item 9, and I think we do have the panel online. Clerk, are we okay for item 9, yes?
Yes, we have officials ready.
Okay, so members, item 9 then is a departmental briefing which we had requested on the recognition payment for health and social care workers. If members recall, we had asked for a definitive date to be provided, and we had then asked in relation to ongoing concern around the issue that the department would brief us, would ask officials to brief us in terms of the recognition. I know there has been some development and welcome development, but I think it is still timely that we have an opportunity to discuss with officials around the details flowing from the announcement that these independent healthcare workers are going to receive that £500 uplift, which they so richly deserve, along with all of their colleagues who they worked alongside. And I suppose it is regrettable that there's been a delay, but hopefully we're seeing some progress. So I can advise members that department officials are here to give a very, very brief update today, members, please, on the recognition payment to health and social care workers. At tab 9.1 of the table pack is a response from the Minister on the issue to us as well. So I'd now like to welcome by Starleaf Mr. Phil Rogers, who's Director of Workforce Policy. Can you hear me okay there, Phil?
I can indeed, thank you, Chair.
And Mr. Mark McGuckin, who is Director of Disability and Older People. Mark, can you hear us there okay?
I can, Chair, thank you.
Yeah, and I just want to check before I go back to you, panel members, I just want to check, Colin, you have your hand raised, it's down there now, so I'll be bringing you in the session, Colin, if there's anything you need to raise, that's okay. So we're hearing you both loud and clear there, gentlemen, and could one of you go ahead and advise in terms of opening remarks, and then we go to members' questions. Thank you.
Certainly, thank you, Chair. With your permission, I'll take some opening remarks or make some opening remarks, and then obviously, as I said, Mark and I are happy to take some questions at the end. So by way of background, the Health and Social Care Special Recognition Payment was first announced in January of this year by the Minister. And its intention was to recognise and provide a token of appreciation to HSE staff who had carried out their duties in the face of the major health crisis presented by the COVID-19 pandemic. The payment was to be up to £500 per person and would be paid pro rata to reflect the individual contributions of staff members. The scheme followed an announcement of a similar scheme from the Scottish Government. As I say, it was aimed at those staff directly employed by HSE and those employed under HSE contracts working for a minimum of 1 month between between 17th of March 2020 and the 31st of January 2021. And then a similar scheme was then later announced in Wales. So we were working on the same basis as our devolved colleagues. Initially, workers supplied by employment agencies were not within the scope of the scheme. However, in February of this year, the Minister then directed that the scope of the payment be extended to also include long-term agency workers in receipt of salaries appropriate to the role they filled within the HSE. Implementation of the payment to HSE staff, however, was not straightforward, and there were a number of complicating factors which posed a challenge to the department and to employers in processing any award. Most notably, it was recognised that there would be tax and national insurance implications related to the payment. And while the Minister requested, in collaboration with his Scottish and Welsh counterparts, that HM Treasury would exempt the special recognition payment from these obligations, that approach was ultimately unsuccessful. Subsequently to that, then, the Minister directed that the overall gross payment should be increased to offset the individual tax and national insurance contributions. And that would ensure then that basic rate taxpayers in receipt of the full award would receive a net payment of £500. And additional funding was then secured to facilitate this change. That meant that someone in receipt of the full pro rata payment would receive a gross special recognition payment of some £7. Another challenge in terms of implementation identified at an early stage was the potential for there to be implications for those in receipt of income assessed benefits. A situation which could adversely affect lower paid workers within health and social care, indeed through the potential of those impacted to receive reduced benefits as a result of receiving a special recognition award. So while the department worked with colleagues from the Department of Communities to explore whether any existing regulations could be utilised to facilitate disregarding of the special recognition payment from income assessment, that was ultimately not possible. And ultimately, the best solution to mitigate the risk identified was for employers to provide staff with the option to receive their payment, their £500 payment, in stages, and to help reduce the effect of payment of any help to reduce the effect on the payment of benefits in any single payment period. Ultimately, a recognition award to HSE staff was completed in July. Payment of the special recognition payment to independent sector and to longer term agency workers has presented its own set of challenges, particularly in relation to governance and accountability. Both sectors work in very different ways, and the department has had to undertake intensive design work alongside employers and trade unions to determine the best way for eligible individuals to be identified and to develop a methodology for how payments will be processed and how validation will be conducted. And as I said, given that the two sectors work in different ways, we've effectively had to design a separate approach for each sector. The design of these methodologies was further compounded, or the complications were further compounded by further trying to ensure consistency could be maintained with the key parameters of the payments that had been made to employees directly employed by the HSE. So it's actually, we wanted to ensure that agency and those in the independent care sector were treated in the same basis as their colleagues directly employed by HSE. And saying an added complication for these workers has been how we could verify that individuals that are no longer working for the providers or agencies have received their payments or will have received their payments. Addressing the various challenges and designing the methodologies to deliver payments to staff has resulted in a significant amount of work for the department, for the board, for BSO, for trusts and others. And I think it is important to put on record the department's thanks and appreciation to all those involved in getting us to the point we are now at. And certainly while it has taken longer to deliver the payments for those staff not directly employed, this does not reflect in any way any difference in value of the work done or the value that's placed on that work. And certainly while we'd like to have been in a position to move more quickly, I'm pleased to be able to confirm today that the scheme has now launched to the independent care sector, to supplying recruitment agencies and to primary and community care contractors, that's to say GPs, community dentists, pharmacists and optometrists. Communications to the independent care sector, setting out the approach to be taken, issued on the 29th of October, to the independent contractors on the 3rd of November and to agency employers on the 5th of November. So that's the up-to-date position, and Mark and I'd be happy now to take any questions you might have.
Okay, and I suppose, you know, I do recognise the fact that there have been complications with the entire scheme, but it's been, I suppose, very unfortunate that there's been a difference made, and then that perception of a different value, I think, has been allowed to kind of fester a bit. And given that has been the case, I think it's vital that we see now an urgency in terms of getting it across the line, and particular and many of these are lower paid workers working in very unsatisfactory terms and conditions. I think it's really crucial that we stretch ourselves to ensure that these staff get this money before Christmas, if at all possible. So in light of that, can you outline for us what support is being put in place for the employers to be able to transition money across, and also what system will be in place for staff members to engage in this, particularly staff members who feel they have unfairly been denied it? Will there be an appeal mechanism, or how will you cater to that situation, Philip?
So if I take the agencies, say we've had to really design two different schemes. So if I talk a little bit about the agency approach, the agency approach will see, we provided guidance, we provided a range of tools to help agencies calculate how much individual staff members are entitled to. There will of course be an appeals mechanism for staff if they feel that the calculation made by their agency is incorrect. The approach we're taking is that the agency staff will then pay, the agencies will then pay their staff up front and then claim that money back from BSO and the department. So that should ensure that we can move quickly to get money paid to the agency staff who meet the eligible criteria. Mark, I don't know if you want to say anything with respect to the independent care sector.
Yeah, certainly, Phil, thanks. In the independent care sector, we've been mindful of the financial pressures that they're under. We have introduced a scheme which will see BSO pay in advance of the providers paying it out to their workers. That's, as Phil said, that scheme is already ongoing, and we have received claims in, and we're working with BSO to try and expedite those payments back to the suppliers as quickly as possible. In terms of any sort of appeal between, in terms of hours worked or hours claimed, we have been clear in saying that the department will not get involved in that, Chair, and that is an issue between the employer and the employee. We have no rule, or we would have no way of verifying the hours that any individual worked for their employer. So we have said that is a decision between the employee and the employer. So we won't be getting involved in individual disputes in that sense, but say we are paying the funds to the employers first, and then they will pay that out to the employees. One of the stipulations is that we would expect that to be paid as soon as is practicable, and as soon as they receive the funds, and no later than 4 weeks after receiving the funds. As Phil has outlined, there are there's part within the guidance which says they can stagger the payments. So somebody may receive their payment over 3 or 4 installations. So there wouldn't be as big an impact on, for example, universal credit payments coming through. So it might take slightly longer to get the payment out if they're staging it. And we are aware, Chair, that some organisations and some suppliers have already paid the £500 out to their employees. And we work with those employers who came to us early to try and get that across the line to ensure that they were paying it out on the right basis. So some firms have already paid it out to employees before they've got the money through. But as I say, we are working to expedite the payments back through BSO as quickly as we possibly can.
Okay, well, I have to say, Mark, I don't accept that as satisfactory that you would take a hands-off approach in terms of the employers. It's a matter between the employers and the staff. This is a £500 payment coming from the department to the staff. So I think we need to ensure we have accountability there, that the staff aren't. And I have to say, there have been raised with us at various times issues of concern where staff have said they've been advised by employment agencies in some cases that they wouldn't be getting any payment. So I think it's crucial that the department ensures that the people who deserve this money and who deserve it by Christmas get it. So I'm a little concerned with that approach, to be honest.
Sorry, Chair, could I maybe clarify? We will ensure that the money is paid out to the providers. It's in terms of the provider saying that, or an employee saying that I worked 14 hours and they've only put me down for 13 hours, for example. We would have no way of getting involved now because we don't have access to the employment records. That would be an issue between the employee and the employer. In terms of ensuring that the payment goes out once it's paid into the supplier to the individual staff, there will be an audit carried out after that to ensure that those payments have been put through, and we've made the suppliers aware of that they have to have a specific, if you like, line on the payroll that says the £500 recognition payment. So there are checks and balances in place, Chair. I wasn't suggesting we wouldn't do that, but it was in terms of that individual sort of employee-employer discussions around the amount of hours claimed, we would have no way of intervening in that, Chair.
Okay, and is there any access point for staff members in the event of a dispute that they can raise it with the department? We
have put up a dedicated email address which my team are monitoring for queries coming in. Now, primarily that is for the employers to send in, but as you'll be aware, as all members on the committee will be aware, individuals have been writing into the Minister, individuals have been writing in through their elected representatives as well. So we will deal, if an individual writes into us, we will take that forward with their employer, and we'll write to their employer if they feel there's something which hasn't been put through, but we have no way of intervening in individual cases, Chair.
Okay, and just finally for me, before we go to members then, will these staff have this money for Christmas?
We are endeavouring to get the money turned around as quickly as we possibly can, Chair. As of yesterday, we had 60 claims received for a value of around £305,000. So the claims are only starting to come in. The letters were issued on the 29th of October, so we are turning them around as quickly as we possibly can. We have committed to turning them around within 4 weeks of receipt, which should see them out as quickly as possible. That's the maximum that we hope BSO will take to turn these around, Chair. So we are doing our best to get that out as quickly as we possibly can, and with a view to try and get this into pay packets before Christmas, if that is at all possible.
Okay, thank you. I'll go then to members. So I'm going to go first of all to our Deputy Chair, Pam Cameron. Go ahead, Pam, please.
Thanks, Chair. So I've just waited. There's a bit of a pause and unmuting me there. And thank you, panel, for your attendance at committee today. Obviously, this has been a big issue for MLAs, dealing with constituents and organisations who've been getting in touch. So the Chair's asked the bulk of my questions anyway, but you did mention that there was a dedicated point of contact or an email address, I think you said, for organisations. But I'm wondering, could that be opened up, or could there be another one opened up to MLAs to help deal with the vast quantity of queries that are coming through, rather than us submitting continual questions to the Minister and writing letters to the Minister and to the private office? It might be actually useful to have a direct point of contact for MLAs so that we can deal with the more intricate queries.
I would be happy to accept that I could be the point of contact for the independent sector for MLA's queries. If that will be helpful, I'll look to Phil if it would be a similar contact on his side.
Yeah, well, I think we could certainly look at that. I think it would be very helpful from our own perspectives in terms of the machinery of government and as you've said, Deputy Chair, the volume of correspondence cases and AQs that we have been having to deal with. So it might be useful to have a sort of a dedicated email address for MLAs to contact the teams directly. We'll maybe take that away, and whether it would be myself and Mark for the two aspects, or whether we'll come up with a single point of contact for both, we'll come back to the committee on that.
Thank you. I think that would be really useful for both the department and for ourselves representing people on the ground. Obviously, the payment has come from a very good place, but I think a lot of people are actually feeling aggrieved because it has taken so long. But we do understand the complexities around the issue. It's probably more complex than any of us had ever imagined it would be. But I would agree with the Chair that we do want to see these payments made as quickly as possible, that people do actually get that recognition as it was intended. So thank you.
Thank you, Pam. And going then to Colin Mcgrath. Go ahead, Colin.
Thank you very much, Chair, and maybe thank you to the panel for giving us the update, notwithstanding and not directed at the panel, but I think that it's not unfair to state that this has been an unmitigated disaster. To have announced to people in January that some of our lowest paid workers that they would be receiving a bumper pay packet, and then some 10 months later to have not delivered that has been really hurtful to them. And I know that many of the people that have spoken to me in my constituency office and in my area just feel so aggrieved that they just wish it wasn't announced at the beginning, because it has just been promised to them for month after month after month. And I am, Chair, a little concerned about the governance angle, because whilst this is about being able to get the payment to the people that have worked on the ground, I think what I'm hearing between the lines, and maybe I could get some comment from the panel, is that effectively our Department of Health does not know for fact, for record, how much money has been paid to people in the independent sector. Because otherwise it would be able to go into that database and work out how much people have been paid, and then it would have been able to give them the recognition. And what I'm hearing is that they're having to go to that independent sector and say, can you please tell us how many hours people actually worked for you? And I'm just wondering, is there a broader issue of public accountability for what would be literally millions and millions and millions of pounds of public money that our department cannot trace and has no record of how many hours these people worked? And I think that this scheme has exposed that. So maybe if I could ask the panel, do you have a database within your department that tells you how many hours people in the independent sector who were paid for by the public purse, how much money they've received for their employment?
I'll take that one if you want, Phil. I think the quick answer to the member is no, we don't. And what we're doing in terms of governance, and I suppose I would take issue as well with the comments about this being an unmitigated disaster, but that's it's obviously the members' own views on this. We've done as much as we can to get this out as quickly as we can, and we have some very dedicated folks both within our teams and BSO and the board working to deliver this. I appreciate it's taken longer than it should have, but we're delivering as fast as we possibly can. In terms of governance, what we expect from the independent sector is that they will provide us with detailed records of every employee they're claiming for, and that will include details of P60 records, redacted P60 records, or P60 payroll claims, which show for the individuals they're claiming for the hours they've worked in the qualifying period, how much they've been paid for that particular year, and we've then provided a database spreadsheet which will calculate how much they're due in terms of the pro rata of the recognition payment. So I would say categorically this, we are ensuring that records are made available to us. We don't have records for every individual employer in Northern Ireland who is employing either someone in a care home or someone in a domiciliary care role. No, we don't have that, Chair, or Colin, and I don't think any other sort of body who's delivering, or government body, would have similar records either, because they're private records between an employer and an employee, and I don't think we would have the necessary data protection or GDPR cover to ask for those records on an ongoing basis. These relationships are managed by the trusts and by BSO. The department doesn't have any direct relationship with the providers who are providing this service on behalf of the trusts. It's the trusts who have that relationship, and it's the trusts who manage that relationship on behalf of the department. So the department has no direct linkages with the suppliers. We are doing our best to make sure that we have proper governance procedures in place to ensure that the prepayment and post-payment checks are carried out by BSO and internal audit within BSO. So I'm content, Colin, that we have a robust system in place for the delivery of these funds.
Several points. First of all, along with myself, Mark, it's the considerable vast number of people in the independent sector that are saying that this is an unmitigated disaster. So don't think that it's just me saying it. It's the majority of people who nearly 11 months ago were promised £500 and haven't received it, and they are exceptionally hurt and they're exceptionally unhappy. And that is why we're here today having this conversation. With regards to some of the other comments, I know that maybe they're not necessarily your side of the house, Mark, and we need to maybe find other avenues for this. But I just take exception at many of those remarks. There could be no GDPR consequences in terms of the government paying somebody to do work and then not knowing who did it. I think that the government can rightly ask how the work's done. I certainly know that I used to work in a part-time youth centre in the voluntary sector, and we had to provide the names and numbers of hours on a monthly basis of everybody that got paid there. I'm certain in the Department of Education they know exactly how many teachers there are within all the various sectors and how much money they're getting each year. And what I'm hearing here is that we do not have a database of the independent sector, of people that work, that get paid by the public purse. And do you have a process then to a question? If you then find that somewhere along the lines, people have been claiming for money for people to do work if they haven't actually been doing the work?
Well, as I say, Colin, that relationship is managed by the trusts. I will ask the trusts if they have the specific data that you're looking for. But again, even in terms of the data protection issues for asking for these claims and the information we need for these claims, we've been advised that we cannot ask for information which we do not need. And in terms of this, all we need is something which says, here's how many the individual payroll number of the individual who has worked, the hours they have worked, and the total work for that year. That is the only information we have a right to ask for to verify their claim. But say I can certainly ask colleagues in the trust and trust finance if they have any data that you've requested. But I'm fairly certain, and I'm only relatively new to the post, Colin, so I may have said something incorrect here today, but I'm fairly certain that colleagues in the trust have a robust relationship with the providers and ensuring that what is being paid for is actually being delivered. And I wouldn't like you to go away with an impression today that there's something amiss and that we don't know what we're paying for.
Okay, thank you very much. Thank you, Mark, and thank you, Philip. Thank you.
Thank you. Deborah, then, moving on to Deborah Erskine. Go ahead, Deborah, please.
Thank you, Chair. And Chair, I would agree with the comments that you've made at the start there. It's important that we're making sure that people are getting paid, before Christmas. Certainly would be great to see, because I know as MLAs we've had so many people on to us asking us when are they going to get this payment. I've had a few questions just in relation to the qualifying periods of time, because it has taken a length of time for it to roll out for the likes of the independent care sector. And for example, students who are on HSE courses that were in paid contracts and things like that. Is there likely to be any change in the qualifying period? Because during that time, we will have seen that people have come in to work. They were still dealing with COVID patients. They were still under pressure as well. So my question just relates, will there be any change in the qualifying period?
I'll take that one if that's okay. I think the simple answer is no. The qualifying period and the eligibility criteria, we've designed them to be consistent with what was delivered for the HSE payment that was made back in July, so that there'll be no changes to the qualifying period.
I thought that might be the case, but thank you anyway for that.
Okay, thank you, Deborah. Going then to Carol Nicullen. Lanare, Carol, with the whole.
Thank you, Chair, and thank you to the panel for this morning. So, BSO work for the Department of Health through the Health and Social Care Board, isn't that right?
Yeah.
Yeah.
Okay, so given that you've said that you're asking for the minimum information from staff, then surely that's not a reason for the undue delay. I mean, this has been delayed and people are feeling very sore over this, to say the least. So why, given the fact that you're just asked for the bare minimum of information, has there been such a delay? And then the other thing is, it is concerning, I have to say, that how do you ensure then staff are being paid fairly if you can't track the money, or if you can't track the volumes of people who are going to apply for this?
Well, I think if I maybe take that one first, and Mark might want to come. I think you're in terms of putting in place the governance, the oversight, the accountability, and the verification processes. That is what has taken the time, and designing those processes and the processes that we've put in place are to give us as much certainty as we can possibly get that the money will be paid to the people that are entitled to get it, and those processes that we've been designing and the methodologies that we've been developing are all designed to ensure that the people who are entitled to the money receive it, and dare I say, that's what's caused the delay in terms of getting to this point. The complications in terms of what information we hold and what information others hold, and trying to make sure that we have the right information to enable us to make the payment and to verify the payment and make sure the payment goes to the right person.
So if you're asking BSO to verify just the basic information, then you don't need to compare to the information you have unless, for example, there's been money issued to agencies and to independent healthcare, because it strikes me that there's a problem here, even regardless of this recognition payment. There seems to be vast sums of public money going out for domiciliary care and independent sector, and there's an issue about tracking it.
Well, those monies that go out for domiciliary care and care homes are based on the delivery of the service they provide in terms of packages of care and delivery of hours of care. So I would reiterate, I don't think there is. I think we're conflating two issues here. The management of that is a role for the board and the trust to deliver on the department's behalf. We don't have a role in delivering that. Our role is in designing this recognition payment and making sure it goes out. We have assurance in the fact that when a provider sends in a return to us saying here are the people who have been employed who meet the criteria, they're sending that off to say that is a true and bona fide claim. BSO will undertake the checks in terms of the probity of that claim, both pre-payment and post-payment. So I'm content that the processes that are in place will provide us with that assurance in terms of governance of public money, that we do know that the money is being paid out, is paid out based on a verified claim from a provider who's been asked for payroll records to verify that claim. I'm not in the space of suggesting that the providers who are delivering very, very significant services on behalf of the trusts would in any way make fraudulent claims, and I'm not suggesting for a moment that's what members are suggesting either. No, but we have put in place as much checks and balances as we possibly can to make sure that everything in terms of delivery and substantial amounts of money is as watertight as we can make it.
So the delays with BSO then?
No, the delay is not with BSO. I'm not saying that at all. Phil has already said the delay was in the development of the governance of the scheme and making sure the scheme was fit for purpose to go out. I think it would be totally inappropriate to say there's any delay in BSO. BSO are turning this around as quickly as they possibly can, including staff working overtime at weekends, etc., to try and move these claims through. BSO have worked very, very collaborative with us in the department and the trust to make sure this has been put through as quickly as it can be. All of us accept there has been delays, and all of us accept that we would have wanted to do this quicker, but we have moved on this as quickly as we possibly can to ensure, as Phil has said, that the necessary checks and balances and governance arrangements are in place to deliver this scheme. BSO have committed to turning this around within 4 weeks of getting the claims in, and we're still working towards those timetables.
So, Chair, just my final question.
Yeah,
the delay with BSO, my reference was that there mightn't be enough staff in BSO to turn this around. And they're right to put balances and checks in to make sure the public money's spent and spent wisely. So no one's suggesting fraud or anything else. But the issue for us here is there has been a delay. It's ongoing. We can't guarantee that these people will have the money before Christmas, despite everybody's best efforts, despite BSO working at night and over the weekend. So the issue may be that there isn't enough staff in BSO to turn this verification around in order to ensure that people get their money before Christmas, and indeed that they're paid.
No, Chair, I don't think that is totally accurate. BSO are doing this within 4 weeks. If there was a delay, the delay was at the department side. I don't think it would be fair to say the delay was in BSO or BSO don't have enough staff. The staff in the department have worked on this continually for the last number of months to get this turned around, and we all accept that we would have wanted it to be done quicker. We have taken the time that was necessary to make sure we have a robust process in place, and Phil has already apologised, and I will reiterate that apology to the staff out there in the independent sector. And the Minister has been very clear and is on record of saying that he wanted this to be done quicker by the department. We've done our best to get it through, and it in no way diminishes the commitment and the praise that the Minister has put out there to the staff in the independent sector.
Okay, thank you. Thank you. And I need to move on then to Alan Chambers. Go ahead, Alan.
Thank you, Chair. Chairman, I think it's we need to say that this scheme was put in place in good faith, and it was fairly easy to get it out quickly to direct employees of the department. But I think that the Minister recognised that to get the maximum benefit to recipients, the department had to find a scheme that avoided tax having to be taken out of the 500, the national insurance, and also the implications that it might have for recipients who are on benefits. So I think that that probably, again, those delays around trying to put in place that everybody would get the full benefit of the money probably did contribute to delays at the very start of the scheme. But I think that those delays, as I say, they were done for the right reasons by the Minister to maximise the benefit to those who were going to receive it. In terms of I think we have to acknowledge that we're talking here public money, and therefore it has to be subject to audit and accountability. And since this money is going to be, this particular part of the scheme is going to be distributed by third parties, I think it's, I would acknowledge that delays, and I'm sure the officer maybe will confirm that the delays are obviously have been necessary to ensure that mechanisms have been put in place to protect public money going to the private sector. And, it all could be open to abuse, but I sincerely hope that would not be the case. But if you remember back to the scheme where the Minister of Finance paid out £10,000 to the ratepayers, there was a vast
Can you get to a question? Can you get to a question, please, Alan? We're a bit tight for time.
A vast number of people got that money that weren't entitled to it, and that money was lost to the public purse. So I think it's due diligence that every care is taken in the distribution of this money. I wonder if the officers could tell me what is the estimated figure of what do they expect to pay out to this particular part of the scheme to the private sector?
So if I maybe take that one, Chair, if that's okay. So in total, 118 million has been set aside in respect of the staff recognition payment. 80 million of that relates to the payment itself, and then an additional 38 million was set aside in respect of the tax and national insurance implications. To break that down, then that 118 million down, directly employed HSE staff would set aside 58.5 million for that. The agency element would be a further 4.2 million pounds, and then for the independent sector staff is the final 55 million, and that includes the independent social care sector that Mark is responsible for, but also then the community focus, the GPs, the pharmacists, the community dentists. That's all included in that independent sector element.
So certainly not an insignificant amount of public funding. Thank you.
Thank you, Alan. And Paula, please.
Thank you, Chair. Thank you, panel. It's just really following on from Alan's question there, and it's around the eligibility of those people who work in independent hospitals who were delivering on some of the elective care during the crises that we felt in our hospitals. Just wondering, are they eligible for it?
So while obviously private providers have undertaken some work on behalf of HSE, they've done so under a charging mechanism, and so unfortunately, no, they're not included in the scheme. Independent hospitals have not been included within the scheme.
Sorry, that's fine. I'm just seeking clarity. Thank you.
Okay, thank you. And I just want to check back very briefly for Pam. I think there was it may have been covered already, Pam, but I'll check with you. Were you looking clarity on something there in particular?
Yes, Chair, thank you. And I think Philip, at the start, I'm not sure if I picked this up right or wrong, did you say that the process or the letters had gone out today for GP staff and pharmacy staff?
So no, that was last week. So I'll give you the dates again, just in terms of when the letters issued to the various sectors. So communications to the independent social care sector issued on the 29th of October. And I say when we say communications, that's the guidance and the various tools that have been provided to help people to calculate what individuals are entitled to. Independent contractors, so it was on the 3rd of November. So that would be GPs, community dentists, pharmacists, optometrists. That was on the 3rd of November, and then the agency employers was last Friday on the 5th of November. The communications issued to them. I should say as well, in terms of the independent contractors, there have been a number of workshops on the 3rd and 4th of November. So following the sort of the issuing of the guidance, then there was a couple of workshops were held. Zoom workshops were held last week with as I say, the dentists, the optometrists, the GPs, etc.
And Chair, sorry, Chair, if I could maybe add one point of clarification as well. In terms of the independent sector, we are doing this in two phases. The letter that issued on the 29th of October was to the main dom care and care home providers. We hope to issue a letter by the end of this week to the supported living sector, and then we still have one sector left to go, which is in terms of personal assistance, which we're still working on to try and do a totally separate process for them, working with colleagues in the Scottish Government. So there is one final element of the scheme which we still have to get letters out to. So I wouldn't want to give the impression that we have done this all in one go, because by far the biggest sector was the dom care and the care home sector and the supported living sector. So we're doing them as the major element of it, and we're progressing on a weekly basis the other elements of it. And as soon as those bits are ready to go, we will issue the correspondence to those individuals.
Okay, thank you.
Great, Mark. Thank you. Thanks, Chair.
Yeah, thanks, Pam. And that actually then raises another cohort that I want to check that has been considered. Those people who are employed via direct payments, they may not be personal assistants but providing domiciliary care. Are those included within the current notifications?
No, they will be, Chair. They will be part of direct. Anyone in receipt of direct payment will be part of that cohort being delivered as part of the personal assistance payment as well, because we hope to use, say, the Scottish Government portal to mop up all of those outstanding issues, and there is an outstanding issue as well for care home and domiciliary care staff who may have moved employers or who have left the sector since this scheme went live, or since the qualifying period. We still have to put in a bit of a separate process for those, Chair, but we move forward to try and move the bulk of these forward in one go when we were ready to do that. So there are a number of outliers as such, which we're still working on, Chair.
Okay, thank you. And I want to thank the Mark and Philip for attending our meeting and for dealing with members' questions there. And I would urge you to give urgent consideration. I know you have undertook to do that, as to how the communication is going to work in this period of time, because I think there is a huge amount of concern and a huge amount of potential for discrepancies. So I just think we need to be providing the resource to address those effectively. So thank you, panel. That's perfect for today. Thank you. Okay.
Thank you, Chair. Thank you very much, Chair.
Okay, members. I think we've covered it all there, members. Just I think we'll move on then to item 10, which is SR 2021/286, Provision of Health Services to Persons Not Ordinarily Resident, Amendment, Regulations NA 2021. I refer members to the Clerk's memo at tab 10.1 and to the other papers at tab 10.2 to 10.4, and also to a copy of the SL1 letter at tab 10.5. As this SL1 was submitted to the committee on the day before the SR was laid, the committee didn't have an opportunity to consider the matter at policy proposal stage. A departmental official is here today to brief the committee on the provisions of this SR. So I'd now like to welcome to our meeting Miss Patricia Quinn Duffy, who's Head of Healthcare Policy EU Future Relations. So Patricia, can you hear us okay?
I can, yes, Chair. Can you hear me okay?
Yep, we're hearing you there, Patricia. So, okay, Patricia, go ahead, please, and brief.
Thank you, Chair. The Department has made the statutory rules provision of health services to persons not ordinarily resident amendment regulations Northern Ireland 2021 SR 2021-286 under powers conferred by Articles 42, 106B and 106.7 of the Health and Personal Social Services Northern Ireland Order 1972. The statutory rule is subject to negative resolution procedure before the Assembly. Article 42 of the Health and Personal Social Services Northern Ireland Order 1972 authorises the Department of Health to make regulations for the exemption of services and charges for persons not ordinarily resident in Northern Ireland for healthcare purposes. The regulations amend the provisions of health services to persons not ordinarily resident regulations Northern Ireland 2015. To implement changes as a consequence of the signing of the Convention on Social Security Coordination between the UK and the Swiss Confederation on the 9th of September 2021. The Convention ensures that individuals within scope who move between the UK and Switzerland will have their social security position in respect of certain benefits protected. This includes reciprocal healthcare cover in the UK and Switzerland. This will be equivalent to EHIC, GHIC, S2 planned care treatment provisions and S1 provisions. As Regulation 883 of 2004 no longer applies to the UK and no longer applies between the UK and Switzerland, and the Trade and Cooperation Agreement is with the EU only, the UK and Swiss both recognise the importance of continued coordination of social security rights enjoyed by persons moving between both states to work, to stay or to reside, as well as the rights enjoyed by family members and survivors, and agreed to negotiate a new modern convention to allow the continued enjoyment of these rights by their citizens. The Convention ensures that individuals who move between the UK and Switzerland and who are in scope will have their social security coordinated in respect of certain benefits, including reciprocal healthcare. The Convention replaces the bilateral Convention on Social Security between the UK and Switzerland agreed in 1968. The Convention does not impact on the provisions of the Citizens' Rights Agreement, which was concluded between the UK and Switzerland on the 25th of February 2019. People who were residing and or working in the UK or Switzerland by the 31st of December 2020 will continue to have lifelong social security coordination rights under the Citizens' Rights Agreement, provided they are and remain in scope of it. When signing the Convention, the UK Government gave an obligation to the Swiss that all UK domestic legislation would be updated prior to the 1st of November 2021. This was not something that would be expected, as in Northern Ireland we have an obligation to implement international agreements under the Northern Ireland Act 1989, even without our legislation being updated. So in order to meet the commitment made by the UK Government, these regulations needed to be in place by the 25th of October 2021, in time for the commencement of the Convention. Unfortunately, this time was constrained, and in order that the provisions within the statutory would come into operation in time for the commencement of the UK-Swiss Convention, the Department did not have any other choice, unfortunately, but to break the 21-day rule. The Examiner of Statutory Rules had been advised accordingly and was content. However, the opportunity was taken to tidy up the Schedule 2 of the Provision of Health Services to Persons Not Ordinary Residents Regulation 2015 to add in countries which the UK has reciprocal arrangements in place and to remove those which no longer has. The tidy up added the Faroe Islands, which is the agreement with Denmark, because the Faroe Islands are not part of the EU, the Ireland agreement that was agreed at the end of December, Kosovo, which was an agreement which has been in place for a while, Norway, which is an older regulation which provides for needs arising care between the two countries until a further, more substantive arrangement is negotiated, and then the new Switzerland arrangement, which is the one that I've been speaking about today. I'm happy to take any questions about the Convention and the regulations, Chair.
Okay, thank you, Patricia. First of all, I suppose I'm wondering, why did this not come as an SL1 to committee? I mean, this is not emergency regulations similar to the COVID regulations that we've obviously expressed concern about, but we have also provided some understanding in terms of the situation that was raised. Why is this one not came through the SL1 process?
Chair, it would have been. The issue was that the UK Government made a commitment that it would be in time for the 25th of October. We hadn't been advised of that until quite late in the day, as we would have been making the amendments, as there are other additional amendments that need to be made to the 2015 regulations, and it was basically because they became urgent, in that we needed to meet the obligation that the UK Government had made to the Swiss, which was unexpected and is not something that we would normally come across.
So we're basically at the mercy of late or slow processes by the British Government. Is that something? Is that not an issue of concern, given the very grave ramifications of this?
It is, yes, Chair, and this is the whole point about the MOU and making sure that our sort of agreements with reciprocal healthcare and further international arrangements are done within enough time, and that what is being negotiated is shared with the DAs in time for us to make amendments within our normal statutory processes. And it is something that has been informed back to the Department of Health and Social Care in London.
Okay, and can you explain then why Croatia, given that why has Croatia been removed from it? And I have to say, I would be hugely concerned around the amount of people who are travelling back and forward to Croatia, but also in terms of even this part of the world where I'm in today, in Dungannon and South Tyrone here, we have a very highly developed food manufacturing and engineering sectors who travel very regularly across many of the areas we're discussing here today, including those Russian areas, in terms of carrying on their business. So it has a significant impact, but why has Croatia been taken out, and what can be done to address the issue of those other states that have been excluded?
because international relations are the UK government's domain, we are in a almost at the mercy of what arrangements the Department of Health and Social Care is going to take forward for the UK as a whole. Croatia is now a part of the EU, so it would be covered under the Trade and Cooperation Agreement, which is why that was removed. This is an update of the 2015 regulations, which haven't been updated in quite some time. So it was just to remove that old agreement, which has been superseded by, first of all, 883, then the Trade and Cooperation Agreement, and so it's no longer necessary to have Croatia in the Schedule 2. The other ones that have been removed, again, yes, we are basically taking what the UK are deciding to negotiate with. And unfortunately, those agreements with those Russian, pre-Russian or states have been removed for quite some time. And we just haven't updated the 2015 regulations to date. So as to make people aware that in the legislation that they no longer applied.
Yeah. Okay, and you had indicated that those who are ordinarily resident up to 2020 will still derive the benefits. What about those who don't meet that qualification? What's going to happen? What's the impact on them?
In terms of Swiss, anybody that was in the country prior to the end of transition will have lifelong rights so long as they continue to meet the agreement's constraints. People between January and September, when there was no agreement with the Swiss, didn't have access to, for example, EHIC or needs arising care, and they would have been chargeable in Northern Ireland, or vice versa if there were people going to Switzerland. From now, it will be as if the Regulation 883 has been put back in place again. So people visiting Switzerland for work or for holidays will be able to use their GHIC, as it will be now. Swiss coming to Northern Ireland will be able to use their EHIC. There will be a planned care route if that is required to Switzerland or back to the UK or to Northern Ireland from Switzerland, and people will be able to move. Say, for example, there are posted workers or people deciding to move longer term or go to college in either of the jurisdictions will be able to use EHICs and or S1s, depending on what is most appropriate.
Okay, thank you. Okay, I'm going to go then to members' questions, and I have an indication from Deborah. Go ahead, Deborah, please.
Thank you, Chair. Yeah, just to say, it's good to see this. I believe, that ensuring visitors to the UK have fair and vital access to health services in times of need is important. I'm just out of interest. I'm just wondering if you can quantify, or if you know how many visitors from Switzerland and other countries will these arrangements benefit, first of all?
It's very difficult to say at the moment because obviously travel is quite skewed at the moment. It really, in Northern Ireland, we would have a reasonable amount, not a huge amount of visitors from other European countries. They tend to be from Ireland, from the Republic, to be honest. But it would be in the hundreds. There is from Switzerland, there would be very small numbers, to be quite honest. But it does benefit for business travellers going to Switzerland. So it has an added benefit for Northern Ireland and the economy for us to be able to use it going out, as well as for promoting tourism and travel, that Swiss visitors can obtain necessary healthcare when they come.
Okay, thank you for that. And then just two other questions. What's the department's policy on charging for access to these services, and is there a current overview of receipts from this? And then the second question, has this convention prevented any unwelcome hiatus in reciprocal arrangements?
In terms of the charging, the policy on charging is that a person that is not ordinarily resident is chargeable unless they fall under an exemption that is in the Persons Not Ordinarily Resident 2015 regulations. There's quite extensive exemptions within that. So that would there would be treatments which are exempt, such as A&E, so accident and emergency are exempt and not chargeable. Diseases which would be public health issues, coronavirus was added to the list, HIV, a number of other contagious diseases are also exempt. So that's to make sure that any person that may have come in contact with those diseases comes forward for treatment or diagnosis. Then you have a lot of exemptions for persons. So, for example, we have anyone that is part of an international agreement or has some reciprocal healthcare arrangements. It's whatever the arrangement with that country is. So for the Swiss, it would be all needs arising care while they're here, and any care that is necessary within the time period that they would be here, so as not to cut their stay short. Then you would have others such as missionaries working overseas for UK agencies, and there's quite a raft of others, and it also includes family members. So there's quite a lot of people that are exempt. In terms of charging, we don't keep centrally figures on how many people are charged and what that charging is. There's a possibility that it may be available through the trusts, as the patient payment officers obviously are the ones that would be looking at those patients who would be chargeable and obviously raising invoices. But it's not something that we would collect centrally. Could you repeat your last question again? It was about the convention and...
Yeah, has the convention prevented any sort of unwelcome hiatus, in the reciprocal arrangements was really my question.
Not really. I mean, I think because of COVID, there hasn't been as much travel. So I don't think as many have been impacted around not having access to needs arising care when they travel to Switzerland. But now that it is in place and things are opening up further, and hopefully into next year, there will be even further openings, and as things hopefully get back to normal, it's good that it is in place now and that people get used to it.
Okay, thank you, Patricia.
Thank you.
Okay, thank you, Patricia. And another one, Patricia, in relation to, and I'm very conscious that we are experiencing workforce shortages across a range of areas. Principally, I suppose, of interest to this committee is the issue of healthcare workforce, health and social care, and including domiciliary care, and also skills and workforce shortages within some of our key industries, again, engineering and food production and transportation. In light of that, do you have concerns that this will impact negatively here in a way that hasn't been fully considered by the British government, and that our own individual needs here and shortcomings are being impacted as a result of this?
I don't believe that the convention itself has any impact on that. What will have an impact on that is the immigration health surcharge and the immigration points-based system. That is what has an impact on staffing. At the moment, the immigration health surcharge is still waived for health and social care staff. But the staff that you're talking about around social care and agriculture and food processing don't fall under the skills visa. So they can't get a visa to come to the UK or Northern Ireland to work. So it's actually the immigration system that is impacting on that, not this convention itself.
Okay. Thank you, Patricia. I don't see any other indications from members, so I think we can go ahead to our consideration. But I do have to say, before you leave, I would be concerned in the detail around this one. I'd also be actually concerned as well around the idea that, the British government are going ahead with things now at the last minute, not giving us the proper time to consult or consider, and that could have a very significant impact. So it is a worrying issue, and I mean I've repeatedly hit that problem as a constituency MLA around the immigration system not matching our needs here in the north and not reflecting or responding quickly enough. The Home Office system in place. But anyway, that's something for another day maybe. But it is worrying, and I think we should reflect that as a committee. So, but I can let you go, Patricia, and thank you for appearing today and for giving us your evidence and answering questions. Thank you.
Thank you, Chair.
Okay. Yeah, I think there are some issues of concern there. Okay, but anyway, members, any other comments to make in relation to that statutory rule?
No, Chair, you've covered them. It's just that this is coming in really late in the day, and I mean that's the issue. And then the other issue is what Patricia didn't say, but it strikes me that the British Home Office have a burn on this stuff as well, which is going to impact, on workforce planning. So just to make that observation.
Yeah. Okay. Well, members, we'll now formally consider the SR. I can advise that the Examiner of Statutory Rules has reported that this SR was laid in breach of the 21-day rule, but that she is content for the reasons for the breach. The SR is subject to negative resolution. Do members have any further issues they wish to raise in connection with the statutory rule? If not, then can I ask members to agree formally that the Committee for Health has considered SR 2021/286, Provision of Health Services to Persons Not Ordinarily Resident, Amendment Regulations NI 2021, and has no objection to the rule. Are we agreed? Agreed. Thank you, members. Okay, members, the next two agenda items then are I want to briefly go back, and I do mean briefly, I'll just check back with Colin. I think Colin was trying to come in at the end of the session on the pay for independent healthcare staff. So, Colin, can you make a brief point there or comment, please?
Sorry, Chair, I think Colin's left the meeting. Okay,
well, so I'll move on then. If we get Colin back in, I can check with him again. But for now, I'll move on to item number, the two SRs. They're relating both of these ones to coronavirus restrictions, and department officials are here to brief the committee on the provisions. I refer you members there to the clerk's memo at tab 11.1 of the pack and to the SR papers at tabs 11 and 12. And I would now like to welcome by Starleaf Miss Elaine Colgan, who is Head of Health Protection Branch 2, Marion McKeever, who works within Health Protection Branch 2, and Peter Looney, who is Deputy Director of COVID Recovery and Strategy within the Executive Office. So, Elaine, can you hear me okay?
Yes, thank you, Chair.
Marion, you hearing us?
Yes, thank you.
And Peter, can you hear us okay?
Yes, I can. Thank you, Chair.
Okay, so I would now like to invite officials to go ahead and brief. Elaine, maybe you're welcome to committee this afternoon, and thank you for briefing committee on these SRs. Can you advise which of you are doing the principal briefing, Elaine?
Yes, so Marion will do the briefing, and then Peter and Marion and myself will together take the questions.
Okay, thank you.
Okay, thank you very much for the invitation to attend today's meeting. So today the committee is considering the two statutory rules, and if the chair is content, I will briefly summarise both statutory rules, and then we'll be happy to take any questions that the members may have.
Yep, thank you.
Thank you. Starting with the restrictions regulations, following executive agreement on the 7th of October, Statutory Rule number 292, the Health Protection Coronavirus Restriction Regulations Northern Ireland 2021, Amendment number 18 Regulations Northern Ireland 2021, was made on the 28th of October. This regulation made the following changes. People are now permitted to move around hospitality premises, including theatres, concert halls, and other indoor venues, enabling people to stand whilst eating, drinking, or watching a performance. Indoor dancing is also permitted. The requirement to maintain social distancing in hospitality settings such as pubs and restaurants has been removed, and it has been moved into guidance, and nightclubs have reopened. The amendment also removed the requirement for a ticket to be purchased in advance for an outdoor event, which aligned to the position already in place for indoor events. And these regulations commenced on the 31st of October. As a result of these changes to the restrictions regulations, for practicality reasons, an amendment was made to the face covering regulations, which also commenced on the 31st of October. Statutory Rule number 291, the Health Protection Coronavirus Wearing of Face Coverings Amendment number 7 Regulations, Northern Ireland 2021, was made following executive agreement on the 21st of October. This removed the requirement to wear a face covering when eating or drinking in an indoor setting when not seated or when dancing in an indoor venue. I've now finished summarising the two amendments to be considered. If I may, I would just like to briefly mention that we do plan to repeal these regulations in the coming weeks and replace them with a consolidation. The Executive has agreed that the current measures in place will remain over the winter period, now that all venues are able to open. This provides us with an opportunity to make new regulations combining the remaining restrictions regulations in place with the face coverings requirements. This is an opportunity to simplify the regulations for readability purposes and improve understanding. While some minor changes may occur in policy, it is not anticipated there will be any significant policy changes. I trust that this has been helpful to members and we are happy to take any questions. Thank you.
Okay, thank you, Marianne. So I suppose the first question that arises for me in relation to that, and I certainly think there's merit and I'd look forward to seeing any simplification. I think there is merit in simplifying the message and simplifying the regulations for usability and enforceability. But given the very worrying numbers that we're seeing at the present time, and you said there's no plans or nothing being looked at in a minute in terms of changes of policy over the winter, how could that be the case with where we're seeing significant increases in case numbers, and we're hearing once again of trusts looking at cancelling operations as a result of widespread transmission? So how does that tally, Marianne or Elaine or Peter, or how could that be the case in a situation with rising transmission?
Thank you, Chair. I'll take that question, and then if Peter wants to maybe add anything on the policy, he'd be welcome to. Whilst at the minute of the consolidation, it won't introduce any policy changes, we are still looking at options for implementation over the winter should it be required. At the moment, cases, yes, are high. They haven't been going up considerably over the last number of weeks, and certainly the our paper of this week wasn't any significant increase apart from in the younger age groups. So we are making plans for the winter and we are looking at what might need to be put in place. But at the moment, it's very much the regulation consolidation is about consolidating the current position. And we are looking at options such as vaccine certification and things like that. So, Peter, I don't know if you want to say any more.
No, I think as we've spoken about before, Chair, I mean, the autumn-winter COVID-19 contingency plan set out a number of measures that could be called upon in response to unsustainable hospital pressures. So whenever we talk about a consolidation and baselining or putting in place the baseline measures, we're not ruling out the need to introduce more measures further down the track. So if that's what came across, that's certainly not what we intended.
Okay, well, leading on from that then, around the current situation and around the enforcement and adherence to the current mitigations and regulations that are in place. A lot of people, and I do see it myself, in places where there appears to be an awful lot less face coverings being worn in settings and a general maybe relaxation by people. Maybe it's to do with the success of the vaccine campaign, but there seems to be a lack of or a reduction in adherence. So can I ask what work you're doing with others, such as local councils, in terms of enforcement in around the rules?
Sorry, if I can take that, Chair. Yes, I mean, I would agree that over recent months there has definitely been a falling off in compliance rates with face coverings. We have seen that. We track the figures in relation to areas like public transport, and public transport, the latest figures would show an overall drop in compliance of about 13% from 87 down to 74-ish between August and October. Similarly, in retail, the polling that we've been doing through Ipsos Mori has shown a slight reduction in face covering compliance around retail, and the people that we surveyed, the figure for face covering compliance fell for the first time in the most recent survey down to about 80%. And I know from personal experience and from anecdotal experience of others that in some settings that is even less. We are working with the sectors to try and make sure that messaging is very clear. I mean, we're aware that in some places signage that was up before has been taken down, or audio messages which would have routinely been used in retail are no longer made. So we've been working with bodies across a range of different sectors to try and make sure that those measures are put back in place. The autumn-winter campaign, again in accordance with the autumn-winter plan, has a communications strand, and the autumn-winter comms programme has 3 focuses, and one of those again will be around face coverings. I think the challenge is that there's different approaches in different jurisdictions, and a lot of people get their news from sort of UK national news. And whenever you see face coverings falling off there because they're entirely in guidance rather than legislation, that has a tendency to seep through to the devolved administrations as well. I know from speaking to colleagues in other jurisdictions that poor compliance rates with face coverings aren't unique to Northern Ireland. In fact, we're probably faring reasonably well compared to some of the other jurisdictions, in particular England, but there's clearly more to be done. We do have an adherence group meeting which PSI and local council attend on Friday, and we want to again look at face coverings to see whether there's more that can be done there to try and promote compliance, particularly as we move into what will be a more challenging time.
Okay, thank you, Peter. And I had seen a hand up from Paula. I just want to check with Paula, and then I'll be going to Deborah, but I'll check briefly with Paula first.
Chair, it was about working with councils, but you asked the question, so thank you.
Okay, so I'll go then to Deborah. Go ahead, Deborah, please.
Thank you. And I want to thank those that have come and give that explanation there. It's just 2 very quick questions. One might seem a little bit silly, but what are the remaining legal requirements applicable to hospital settings? I mean, speaking to local businesses in the hospitality sector in my area, they feel that they've been disproportionately hit by the pandemic. So the removal of the legal requirements in terms of consuming food while sitting and social distancing is providing some relief to those establishments. And then my second question is really in relation to that. Is there any evidence to indicate whether restaurants or bars have chosen to retain certain requirements or mitigation measures that were in place?
Thanks, Deborah. I'll start that one, and then I'll maybe hand over to Peter for the second half of that question. The remaining requirements on hospitality are around gathering visitor and attendee information, so for the contact tracing purposes. So every person that is in a restaurant or a bar or cafe, every single person's details should be taken by that hospitality venue. And it's important to make that distinction, because previously in the regulations around this time last year, it was only the lead booker that hospitality had to collect the information for, and they actually need to do it for every single person there. The only exception for that is large events where it's ticketed and where there's a fixed start time. And then if tickets are bought in bulk, it would be a bit more difficult to get every single person's information. So that's the first requirement. Hospitality venues still have a risk assessment requirement, I think, Marion, and I'll just look at Marion, she can confirm she's nodding, so that's right. So that they still have the requirement to do the risk assessment and work out the appropriate mitigations that they should have in place to keep visitors to that venue and their employees safe. And I think that's largely it. I'm going to look at Marion just in case I've forgotten anything.
And then there's just the face covering requirements as well.
Oh, yeah. So the face covering requirements do apply to the staff as well as the customers. Peter, do you want to talk a little bit around the evidence of any retention of social distancing, etc.?
Yes, absolutely. Again, it's a bit of a mixed bag. We do meet regularly with the likes of Hospitality Ulster and the Hotels Federation to look at how the restrictions and the relaxation of restrictions are impacting on them. We have heard from both those bodies that some of their members are retaining different approaches to the mitigations. We have been told that in some settings there is a retention of the requirement to be seated while eating or drinking, and customers don't move around and go up to the bar to get their own, and that appears to be being driven by customer choice. We have heard from some venues that they are retaining social distancing at either a metre or 2 metres, rather than adopting the COVID status certification on a voluntary basis, because again their customers feel more comfortable with social distancing. And then obviously the third major mitigation is that voluntary scheme of COVID status certification, and we have talked about that before at this committee in the context of large events. And we met with Hospitality and Hotels Federation shortly after the relaxations came in to understand how well it was working in their sector. I think, to be fair, we don't expect compliance rates within hospitality to get anywhere near as high as they are for events. Events are much more structured, much more organised. You have a small body of organisers responsible for a critical mass of the events. That's just not how hospitality is set up. But we are working with the industry bodies to try and promote uptake of the voluntary scheme. The digital solution for domestic COVID passes was launched by the Department of Health earlier this month. And they, again, have been engaging with the sector and will continue to engage with the sector to demonstrate how that digital solution works. And actually, it's a really streamlined, really simple solution. And it is much easier to operate than sort of requiring a variety of different proofs, hard copy proofs on the door. So we'd be working with hotels and hospitality to try and promote the uptake of that scheme.
Thank you.
Okay.
Sorry, can I just add as well, just to clarify the visitor information, it's only for persons aged 16 and above, so children's details don't need to be collected under the age of 16.
Great.
Thank you. And actually, I think there is, a kind of almost a welcome message within that. And I've said this before, I would certainly urge individuals, but also business, to take the regulations not as a maximum, but as a minimum, and to do everything they can, practically and sensibly, to protect themselves individually or their customers where it's business or whatever. So I think it is appropriate that people, and I do think that people actually will vote with their feet to an extent, that they won't go to businesses or venues that they feel are unsafe in the current climate, and I think that's something for us all to consider. So listen, I don't see any other indications there from members, so I want to thank Elaine, Marion and Peter again for coming to committee and presenting on these SRs, and we can go ahead now with our formal consideration. Thank you.
Thank you, Chair.
Thank you, Chair.
Okay, members, so moving on then to formal consideration of each of those SRs in turn, as we normally do. And I'm going first of all to SR 2021/291, the Health Protection Coronavirus Wearing of Face Coverings Amendment Number 7, Regulations here 21. I can advise members the Examiner Statutory Rules has no issues to raise in relation to this SR, which is subject to confirmatory resolution. Have members any further issues they wish to raise in connection with this rule? No, thank you. If not, then can I ask members to agree formally that the Committee for Health has considered SR 2021/291, the Health Protection Coronavirus Wearing of Face Coverings Amendment Number 7, Regulations NI 2021, and recommends that it be approved by the Assembly. Are we agreed? Agreed. Thank you, members. Item number 12 then is SR 2021/292. I can advise members that the Examiner of Statutory Rules has no issues to raise in relation to this SR, which is also subject to confirmatory resolution. Have members any further issues they wish to raise in connection with the statutory rule? No, thank you. So then can I ask members to agree formally that the Committee for Health has considered SR 2021/292, the Health Protection, Coronavirus Restrictions, Regulations NI 2021, Amendment number 18, Regulations NI 2021, and recommends that it be approved by the Assembly. Are we agreed? Agreed. Thank you, members. Moving on then, members, to the Health and Social Care Bill Addendum report. Members will remember that the committee agreed that it was content with the departmental amendments to the Health and Social Care Bill at last week's meeting. An addendum to the committee report on the bill is at tab 13.1 of the pack. Are members content with that addendum report as drafted? Members are content, thank you. Moving on, members, to item 14, Severe Fetal Impairment Abortion Amendment Bill, Final Report Deliberations. So, members, we will now formally consider the final draft of the committee report on the Severe Fetal Impairment Abortion Amendment Bill, and agreement will be sought on each of the sections. A draft of the final report is at tab 14.1 of the pack. Have members any comment to make on the draft report? No? Okay, members, then. Yes, Pam, go ahead.
Yeah, thanks, Chair. It was just to say that really, I suppose from my and my party's point of view, we would have a bit of disappointment in the report and the way it's been going, because obviously the bill itself is very concise and very limited in where we go with that, and I just don't think that the inclusion of some of the issues, such as calling for the full commissioning of abortion services, is really appropriate. I understand that we took a vote on this last week, and certainly our party's vote was lost in that. But I did want to put it on record that really, that this bill is very specific, and we are veering down other issues which really are very loosely connected to the bill itself. And I just want to put on record my objection to that. And that I think it shouldn't be included in this report.
Okay, and and your point is noted and is on the record, Pam. And you're right that we did vote on the issue last week, and we agree that. But your point is on the record, and thank you for that. So, members, then can we move then to final agreement in terms of the various sections of the report? And Paula, yes, go ahead, Paula.
Sorry, Chair, I thought you were moving off the subject. I can come back to it afterwards, thanks.
Okay. So, members, I'm going through then and refer members, first of all, to the title page, table of contents, and committee powers and membership at pages 126 to 128 of the pack. Are members content with this section as drafted? Yep, thank you, members. I refer members to the executive summary at pages 129 to 130 of the pack. Are members content with this section as drafted? Yep, thank you, members. I refer members to the introduction and committee approach at paragraphs 1 to 22 of pages 131 to 134 of the pack. Are members content with that section as drafted? Yep, thank you, members. I refer members to the consideration of the evidence received on the bill at paragraphs 23 to 126 of pages 135 to 156 of the pack. Are members content with that section as drafted? Yeah, thank you. Moving on to refer members to the clause-by-clause consideration of the bill, which is at paragraph 127 to 133 on page 157 of the pack. Are members content as drafted? Yeah, thank you, members. And I refer members then to the appendices, which are pages 158 to 171 of the pack. Are members content with that section as drafted? Yep, thank you. Are members content that the minutes from this meeting are approved by the chair so that they can be included as part of this report? Yep, members content, thank you. And are members content for committee staff to make any necessary formatting changes in advance of electronic publication? Yeah, members content, thank you. So in terms of the publishing of the report, I now put the question that the Committee for Health is content for the report on the Severe Fetal Impairment Abortion Amendment Bill to be published. Are members content? Yeah, thank you.
Yeah.
Yes, go ahead, Pam.
Yeah, it was just, I suppose, just to have my wording corrected in our party's objection, if that could be included in the report, that we reiterate our opposition to including a call for the full implementation of commissioned abortion services within the text of the report. Just to put that on record, Chair.
Yeah, well, I think that will be reflected in the minutes of the meeting, Clerk. Am I correct to say? Yeah, so that's on the record there. Okay, and thank you, members. I would also like to seek agreement to issue a link to the report to the organisations who provided evidence to the committee and to the bill sponsor. So the bill sponsor and those organisations will have a link provided to them directly. Are members content? Yep, thank you. Okay, thank you, members. We're now moving on then to... Yes, go ahead, Paula. Go ahead.
Thank you, Chair. It's a long meeting. I'll not take long.
Paula, I'm just checking, Paula. Is this AOB that you're raising?
No, it's really in connection to the report and the recommendation that was within it.
Okay.
I raised the issue a couple of meetings ago and asked the clerk to look into the legal position as regards the current court ruling and the bearing because of the judge's ruling in relation to the Secretary of State's role in this. So I just wondered if we can get an update on that. I also would like, because of the committee agreed to include the reference to the Minister getting on with the abortion services, if we can ask for an oral briefing, not a written briefing, on progress from the Department in regard to that, please.
Yeah. Okay, so I'll check with Clerk then in relation to the legal situation. Clerk, do you have any update on that, or can you advise, please?
Unfortunately, Paul, I don't have an update on that yet. I will chase that up and see where we are with that. But I'll do that after this meeting.
Okay, thank you. And are members content to schedule an oral briefing in relation to the commissioning of those services? Yeah, members content. Thank you. Okay, members, moving on then to item 15, which is correspondence. And I draw members' attention to correspondence, which is tab 15 of the pack. There's a couple of items I want to flag up to members today. First of all, item 15.4 is a response from the Minister in relation to the committee's request that the Department forward the advice that the CMO and CSA supplied to the Health Minister in respect of the easements provided for in SR 2021/276. So have members any comments they wish to make in relation to that response?
Chair.
Yes, Pam, go ahead.
Yeah, just to say that I think the response is disappointing, although I don't think any of us are surprised at the response. We've obviously consistently argued that the Department should be open, transparent and straight with the public on the rationale and the evidence underpinning the pandemic health response. So, I mean, is there anywhere else for us to go on this? Can we put out the same question to the Executive Office, for example?
Yeah, Clerk, what's your thoughts on that?
Certainly the committee can request the same information from the Executive Office.
Any other thoughts, members, in terms of that? I have to say I agree. It is a disappointing response. I think it puts us into a further arm's length distance if we're seeking to follow up with the Executive Office. There is a committee, a statutory committee, which is charged with kind of scrutinising the executive. So I think it's unsatisfactory in that regard. But members' thoughts around any of that, or anything? Do members have any objection to writing to the Executive Office, or any other suggestions that they want considered? No. Okay, members agreed. So let's forward that to the Executive Office and see can we get some more detail coming through. And again, I have to say, along with the rationale, it's also important to see what else is being considered, what else maybe should have been considered, and the whole issue about what worked or didn't work well, I think, remains opaque, and regrettably so. I think it would be great if we could have tracked where changes, what impact they had on transmission, so that as we move through further stages of COVID-19, as we are doing currently, we could have learnt from our previous experience. Okay. Moving on to item 15.7, which is a departmental response to the committee's request for further information following the October monitoring briefing on the 30th of September. Do members have any comments they wish to make in relation to that response? No, that's okay. Yeah, go ahead, Pam.
Right, you on 15.7, like October monitoring?
Yeah, on 15.7, yeah.
Yeah, it was just in relation to the additional investment in mental health services. And obviously this is very welcome, but the fact that it will be used in part to simply maintain psychological therapies rather than enhance access to CBT and other forms of counselling, I kind of think it does show the serious challenges that are facing the system. And as well as that, the issue of the quality screening for the pay award. And I'm wondering, should we as a committee be writing to the pay bodies about this issue? You know, the fact that really that the issue of equality screening has been batted away by the department, and it's really been put on others. I don't know what you think.
Yeah, I agree. I think equality screening is hugely important, and the sums of money and the investment that are being discussed here have huge impacts, either negative or positive, on people. So I do think it is something that we should get further information on. Are members content? Yeah. Okay. Is that okay, Pam? Is that your?
Yes. One other part to that same one was really the funding for the telephone systems for GPs. You know, so and that financial support given to enhance direct patient contact, and obviously we recognise the extreme pressure that GPs are under, but we also recognise that there are vulnerable sections of our community who in particular need, a scaling up of direct face-to-face contact. And we understand, where the GPs are coming from that, but, we do need to see a way in which people who can't easily access or use smartphones and telephony, a way for them to actually access that help and assistance that they need from the GPs.
Yeah. Okay, so just I'll check with Clerk in relation to that final point of Pam's then. Maybe we might have to come back to that, do we, Clerk? Can you give us a wee heads up?
Yeah, Chair, just to outline, we're down to 4 members and therefore don't have quorum to make any decisions. So I would probably suggest that in relation to the correspondence that we haven't considered, that we just roll that over to next week. Or if members want to make any other suggestions, I can do that in that via email. So we can as well. So we can't really make any further committee decisions.
Okay, so that's the situation we're in. We are conscious it has been an extremely long and a full meeting. So we'll roll those forward and bring those forward to the next meeting. Okay, so moving on then, members, to item 16, forward work programme. Are we okay to note that, Keith, in the current, or do we roll that forward? We can note.
No, we can note that, yes.
Are members content then to note the forward work programme at tab 16.1? And any other business then, members, bearing in mind that we is there any other business today? No, thank you. So members, then our next meeting will be on Tuesday, the 16th of November 2021 in room 30. So that's an additional meeting. Our second meeting next week in room 30 at 12:45. And in that meeting, we will be briefed by the bill sponsor on the hospital parking charges bill. So that will be Aisling Flynn will be briefing us on her bill for hospital parking charges. Also, if I could remind members that there will be an informal session with social workers to inform members of the current adoption process to assist us in our scrutiny of the Adoption and Children Bill. And that will take place tomorrow morning at 9:30 a.m. via Microsoft Teams. So if I can just remind members about that and to log in tomorrow morning at 9:30 for that informal session with the social workers on the bill. So thank you, members. Please take care, and I appreciate your attendance and your contribution today. Thank you.